So, welcome to the THET conference. This is always a very, very special moment for us. It's a celebration of the health partnership community, and it's a celebration of the role THET plays in convening that community. There are immeasurably difficult and challenging times, both at home here in the UK and abroad, but health partnerships continue, and born of the enthusiasm and expertise of countless health professionals who know the value of collaborating across borders. At this conference, for example, we will be sharing the results of our Ipsos Mori study, commissioned by THET and funded by Health Education England. At its heart, these findings show that overseas training could improve NHS workforce retention, as over 3/4 of clinicians are keen to participate in global health activities. That was a survey of more than 1,000 NHS staff, and it's a real affirmation of the appetite across the UK NHSs for that global engagement that the health partnership community promotes. For THET, there are a number of very positive developments that we will be celebrating at this conference. First, the launch of our new strategic plan, Partnerships for an Interconnected World, as well as expressing our passion for universal health coverage and for the role health professionals can play in achieving this as clinicians and as advocates. The strategy is a statement of belief that, in the words of our new Chair of Trustees, Justin Ash, the most effective health systems are the ones best equipped to learn globally. Despite the immeasurably difficult and challenging times, you will learn at this conference that THET is expanding its work with the launch of a new program focused on antimicrobial stewardship, the launch of work in northwest Syria, the continuation of our work in Myanmar despite the coup. So there are lots of positive amidst the challenges. And here in the UK, THET continues to make the moral case for UK aid, pointing to the mutual benefit of a globally engaged UK and NHS. Our HEAL campaign mobilises health professionals to speak up on the importance of 0.7% commitments. Our Experts in the Midst programme celebrates the contribution being made by diaspora and internationally recruited staff and looks to overcome the unconscious bias and racism that they often experience. We are in for a treat over the coming 2 mornings, whether you're live with us now or whether you are catching up with this. Every session is recorded. We have over 61 speakers, and we've just gone past the 300 participants mark, which is fantastic, in countless countries. So thank you to all of you for engaging in the conference. Thank you for the work you do in global health. And thank you also to our conference sponsors, whose support makes it possible to keep ticket prices low and free for colleagues in low middle income countries. Thank you to Health Education England, to the Wellcome Trust, to Johnson & Johnson, to Healthcare UK, the Bill and Melinda Gates Foundation, and Insignia Global Partners. It now gives me great pleasure to turn to Dr. Tedros, the Director General of the World Health Organization, to provide the opening welcome.
My dear brother Eldred, Excellencies, dear colleagues and friends, the last 2.5 years of the COVID-19 pandemic have been a painful lesson in an old truth. Shared threats demand a shared response, working together in partnership. In these challenging times, solidarity is more important than ever. This makes conferences like THET all the more important because you're building bridges across borders and across disciplines. I applaud your recognition of the value of learning from each other on delivering quality care, especially at the primary healthcare level, which is so critical for promoting health and preventing disease. As my friend Lord Crisp says, all countries, north and south, Rich and poor have lessons to learn from each other. I thank TED for everything you're doing to support health workers in so many countries for a healthier, safer, and fairer world. I thank you.
And we thank you, Dr. Tedros, for inspiring us consistently, particularly around your appeals for global solidarity when it comes to, for example, vaccine equity, etc. THET is proud to be an NGO in official relations with the World Health Organization, and it's fantastic to have you open our conference. So I'd now like to say that we're moving to the opening plenary, and this will set the tone for the conference as a whole. To say we live in difficult and challenging times is, of course, an understatement. We live in a highly contested world, and I was inspired by Muzam Malik, who's the former Director General of FCDO, when he said, the answer to a more contested world is not endless contestation, but endless collaboration. And what this conference is trying to achieve is to recognize that there are grounds for that contestation. There are legitimate reasons why we have contestation. We are thinking increasingly about racism, as I've already said, about decolonization. We are far from achieving gender parity. There are so many reasons, legitimate grounds for contestation, but it is our belief that the answer to contestation is to recognize those reasons for divergence of opinion, but to aim for collaboration. The answer to into a contested world is not endless contestation, but endless collaboration. We meet at a time of great crisis, also with the World Health Assembly meeting happening in Berlin over the weekend. We are now in the countdown to the midpoint of the SDGs. We've got the high-level meeting on UHC coming up next year. It's obviously the timing is critical, and we are adrift. There's no question we're adrift on our aspirations, which is problematic. The three speakers we now have are absolutely fantastic, and it's a privilege to have been able to invite them. From them, we will get a sense of the big themes that will guide our conversations over the course of the conference. First of all, I turn with great pleasure to Richard Horton. Richard won't mind me saying, I think I've been chasing him for the 7 years that I've been CEO of THET. I chase him partly because of his friendship of Eldred Parry, Eldred Parry, our founder, and I know he has an affection for THET and for Eldred. But I chase him mostly because, for me personally, his offline articles in The Lancet are a guiding light. They are a source of motivation for me. They restore my sense of outrage about the world we live in and my motivation to improve it. So without further ado, if I may, I'll hand over to Dr. Richard Horton. Thank you for joining us.
Thanks so much, Ben, and it's a real pleasure to be with you today. You know, these hybrid events have really transformed meetings. It's tremendous to be able to see on the screen here that we have friends from Uganda, Zambia, Sierra Leone, Ghana, Botswana, Nigeria, Wales, and even Yorkshire, which is its own nation state, of course. So welcome everybody, and it is a moment to gather and reflect on where we are. Now, Ben has already said, and if I can put it in this way, we're meeting at a moment of, frankly, civilizational crisis. Experts far more knowledgeable than I am are debating the beneficial outcomes of a tactical as against a strategic nuclear war in Ukraine. That's hard to believe, isn't it? And yet it's true. Meanwhile, the United Kingdom and a great deal of Europe is facing the kind of economic challenges that are going to scar communities for a generation. And these immediate threats, threats right now, today, are taking place in the shadow of an intensified, not a diminished, but an actually intensified fossil fuel exploration and extraction. Over the next 2 decades, at least $20 trillion will be invested by the oil and gas industries in further fossil fuel extraction. Now, the political conditions that we're working in, unfortunately, are no better. Authoritarian regimes are tightening their grip, suppressing freedoms, repressing minorities, violently putting down protests. And our democracies, which we value so much, really seem quite fragile, brittle, uncertain how to respond. And at times, at our worst moments, at our darkest moments, it feels that we have descended into chaos. At several meetings that I've attended recently, I've heard the present moment described as a perma-crisis, a poly-crisis, a multi-crisis. And one of the most depressing newspaper headlines I read recently was last Saturday in the Times business pages, and it went like this: arms, drugs, and tobacco seen as safe haven in troubled times. So that's where we're at. So one might ask, what on earth can THET do? What possible contribution can THET make to respond to this catastrophic period in our history? Well, I'm going to be relentlessly optimistic because I believe that THET can make a decisive contribution. And the reason why THET can make a decisive contribution lies in the title of this conference, which I cannot underline and emphasize enough, because the only way out of this chaos is through partnership, through cooperation between diverse voices. And that has to be our daily mission. Now, let me give you one example from the Lancet of what I mean. In March this year, we published the Lancet Nigeria Commission, which was the result of a 2-year collaboration between Nigerians in Nigeria and a Nigerian diaspora in the United Kingdom, the United States, Australia, and around the world. The goal of the commission was to re-energize health policy in order to achieve universal health coverage. Now, there are many challenges facing Nigeria, and the commission recognized those challenges, but it too took a decidedly and deliberately optimistic view. Nigeria is a country of over 200 million people, as you know, with immense human talent, a diaspora spanning the globe. In fact, Nigeria's most precious resource is indeed its people. And so under the banner of One Nation, One Health, the commission that was led by Professor Ibrahim Abubakar from University College London, but he lives a double life in Nigeria and London, made specific recommendations for healthcare reforms, extending health insurance to 83 million Nigerians who can't afford to pay their premiums, envisioning a future for Nigeria's health without the dependence on foreign aid, and using the lessons of the pandemic to strengthen Nigeria's health security. In May, President Buhari, we published in March, in May, President Buhari of Nigeria signed the National Health Insurance Authority Bill into law, specifically citing the Commission as one motivating force. And that example tells me that cooperation with positive intent can overcome political deadlock, can overcome pessimism, and can overcome that sense of hopelessness that can sometimes infect our minds when we contemplate global predicaments today. But I do want to be realistic as well, because we have to confront a difficult reality that although it is absolutely true that a country's most precious resource is its people, for a partnership to work, you have to have partners. And by which I mean health professionals. And here in the United Kingdom and Europe, we have a serious workforce crisis. We went into the pandemic with insufficient healthcare workers and suboptimal skill mixes among those workers. And when the pandemic struck, we saw how difficult it was to create surge capacity and to maintain essential health services. And our health workers and health workers around the world have faced unprecedented pressure and stress, heavy workloads, physical, mental health risks, even experiencing violence and harassment. But our health workers, and let's say it together, have been determined. They've been agile. They've adapted services to new requirements and responded brilliantly to a dramatic increase in health needs. Partnerships, so essential, but these partnerships will struggle unless we strengthen our health workforce. Because for partnerships to thrive, we have to have a new emphasis on recruitment, on retention, on distribution to undeserved areas, and on better strategic planning and investment. And in my country, the United Kingdom, we are not in a good place. In addition to a ballot among nurses for striking, junior doctors have been treated appallingly by successive governments. It's great to hear from Ben the commitment of people in the NHS to take part in international partnerships. But our young doctors are under so much stress that in January they are going to take a vote to decide whether or not to strike or not. They've seen their pay fall in real terms by over a quarter over the past decade or so. But the challenge isn't only about people. We have to cherish our people, but it's also about institutions. Medicine forever has relied on a trickle-down model for the way in which knowledge advances health. And the idea is that by simply enabling medical scientists to pursue their quest for knowledge autonomously, society will somehow eventually reap the benefits of that work. But that model is bankrupt. Trickle-down knowledge has the same credibility as trickle-down economics. In other words, no credibility at all. We've got to change the model. And we published a proposal to do so about a year ago by the current president of the United States National Academy of Medicine, Victor Zhao. And he argued that our academic medical institutions need to go beyond research, beyond even service provision. They have to decide, we have to decide, what is it that we actually stand for? We have to understand our role as institutions within broader society, to think about the societal implications of the work we do, the impact of the political, economic, social, and environmental determinants of health on the communities who we serve, from attacking structural racism to rebuilding public trust in science. Our institutions in medicine cannot escape their responsibilities towards equity and social justice. So retooling our people, giving them more support, and remodeling our institutions are two absolute central priorities for strengthening partnerships in the future. But I want to also briefly mention three specific responsibilities that I believe we have if we're going to see partnerships thrive. First, the idea of healthcare in a pandemic world. Second, the climate emergency. And third, and I'm going to be a bit domestic here, I want to talk a little bit about the United Kingdom as a country in global health. So first, healthcare in the pandemic world. We published recently a Lancet Commission on lessons for the future of the COVID-19 pandemic and concluded, not surprisingly, that the response globally was a massive failure of rationality, a failure of the norms of public health practice, a failure of collaboration, and a failure of international solidarity. Again, we come back to this word, the importance of partnership. Because after declaring a public health emergency of international concern, and I absolutely admire and recognize Tedros's leadership on that, WHO was sadly too cautious and too slow in the immediate aftermath of that declaration. Governments around the world, almost to every government, were too slow to understand the seriousness of the threat and too slow to act. There was inadequate coordination between governments. Epidemic control was seriously hindered by public opposition, whether it was face masks or even vaccines. And there continues to be to this day, a failure to address disparities in the impact of the pandemic, the impact on essential workers, including health workers, children, women, older citizens, those with chronic illnesses, among many others. Vaccines, yes, were a triumph of science, but a devastating failure of implementation, again, because of a lack of cooperation between countries. And sustainable development, the backdrop to all of our work, has been severely set back. So a key lesson for healthcare in a pandemic world has been the importance of having a resilient health system as the foundation, the fundamental building block for pandemic preparedness. But that lesson, how quickly we seem to have forgotten it. And THET can play an absolutely critical part in advocating for robust primary health care, equitably and efficiently delivered, for protecting vulnerable communities. We need explicit commitments by governments to universal health coverage, not from ministries of health, but from presidents and prime ministers. Universal health coverage is the essential foundation for global health security. Now, let me turn to the climate emergency, because if you're regular readers of Nature or Science, you will have read articles recently about declining forest resilience under climate change, acceleration of ice shelf loss in the Antarctic, rapidly increasing ocean acidification, and are edging towards multiple tipping points beyond which we will definitely exceed the Paris targets of 1.5 to 2 degrees Celsius above pre-industrial levels of temperature. The outlook isn't good. The outlook is not good, and we've badly underestimated the scale of the changes we have to make to the world's economy to limit global heating, because our lives continue to be dangerously dependent on fossil fuels. The energy transition from fossil fuels to renewables is more unpredictable than we have hitherto acknowledged. And the velocity of political change needed to meet the Paris commitments risk creating unprecedented geopolitical tensions, and we're seeing those today. So what part can we in our community of health workers play in this massive challenge? Well, I believe that we have a central role in generating, in disseminating and amplifying the science of health and climate change. Not that trickle-down model that I mentioned earlier, but concerted, science-based activism. From our own Lancet Countdown on Health and Climate Change to the recent petition to develop and implement a fossil fuel non-proliferation treaty, there's so much that we in THET, that you, that I together can do. Let me finally turn to the role of my own country, the United Kingdom. Now, I'm old enough, I'm 60 years old, and I'm old enough to remember with great pride, the part the United Kingdom played in global health during the Millennium Development Goal era, 2000 to 2015. We were a champion of multilateralism. We progressively achieved the goal of 0.7%. We were an early and consistent supporter of the Global Fund. We convened international conferences that made a real difference, from sexual reproductive rights to nutrition. We diplomatically engaged from DFID and the Department of Health in all major global health initiatives. And then around 2016, it all changed. We stepped back. Now, I don't want to relitigate the causes of why we stepped back. Brexit, the change in political climate to a more populist nationalist agenda. Let's not look back. We have to look forward. But we have a government today, and we need to say it, I'm afraid, that is withdrawing from its public commitments to tobacco control, to dealing with the obesity epidemic, to climate action, to producing a response to growing inequalities, and a migrant policy that is openly racist. It was, frankly, excruciatingly embarrassing to open my copy of the Times on Monday this week and to read the British Executive Director of the Global Fund, Peter Sands, having to write in the national newspaper, pleading, begging the UK government to make a pledge to invest in the Global Fund that he leads, after the United States, Germany, Japan, Canada, France, and the European Union have all made public pledges. We have not yet done so. But let's look to the future, because this is where you and I and THET, health workers and the academic medical community, must strengthen our voice domestically and internationally. We cannot rely any longer on the government to lead on health and health science. It's up to us now, you and I and organizations like THET. So I'm going to conclude. I want to pay, in my last few words, a real special tribute to the work of THET, to Ben and the whole THET team. Health is not a product dispensed by donors or a drug company. Health is a quality that is created in communities. And THET invests in communities, works with communities in extraordinary partnerships to protect and strengthen those communities and to strengthen health. Long may your work continue to thrive, Ben, and the Lancet and myself will always be a loyal supporter. Thank you very much indeed.
Richard, I can't begin to thank you enough. I've and sort of feel quite emotional about some of what you've said. I've got 4 pages of notes which are full of questions, and what I'm going to have to do is discipline myself not to ask them now, because we'll turn to our other keynote speakers, but B, ensure that it's not just my questions that get prominence. So if people have questions for Richard, please do engage in the Q&A, and we'll make sure that we get answers to as many of them as possible. That opening keynote was everything, frankly, that I could hope for. We're terribly grateful, Richard. Let me turn now, though, because Richard will stay with us until the end of the session, and hence I'm sort of confident we can have a Q&A later. But let me turn now, please, from the global picture to a national picture. So looking specifically at Zambia, THET and health partnerships have flourished in Zambia for many decades. We've had a presence with a staff team since 2009. And it's therefore with great pleasure that I invite the Honourable Sylvia Masebo, the Minister of Health from Zambia, to now give the next keynote speech. Thank you, Minister.
The World Health Organization Director General Dr. Tedros, the representative of the UK government, the Tropical Health and Education Trust's THET CEO, Ben Sims, distinguished speakers, invited guests, ladies and gentlemen. I'd like to express my gratitude for this invitation to give a keynote speech at the Tropical Health and Education Trust, THET 2022 Global Health Conference. The theme of the conference this year is Reframing Health Partnerships, Diverse Voices in a New Era. The future of health is indeed around strong partnerships. This is because together we are stronger. Following the ushering in of the new government in Zambia in August of 2021, under the leadership of His Excellency, Mr. Hakainde Hichilema, the country has been commended by cooperating partners for its improved transparency in data management and reporting, as well as its commitment to increase budget credibility, as these are essential to restoring physical sustainability. This will lead to increased investments in social sectors such as health. Invited guests, ladies and gentlemen, I'd like to acknowledge my ministry's partnership with THET, which has been in existence since 2009. Through this partnership, several interventions have been implemented. These interventions have contributed to the improvement of health in Zambia. From 2009, THET has helped Zambia to address some of the country's urgent health needs through quality improvement, health system strengthening, and the enhancement of health worker education. The Tropical Health and Education Trust and the Ministry of Health Partnership has included working in collaboration to develop Master of Medicine degree programs in anesthesia, pathology, and psychiatry, and the first Bachelor and Master of Science in Human Nutrition available in Zambia. In addition, the Ministry of Health has also worked with THET to develop training programs for biomedical technicians in the country. The trained biomedical technicians are working in various hospitals to maintain medical equipment. Through this partnership, Zambia and UK health professionals have worked together to improve medical education. This has resulted in skills improvement in nursing care, medical equipment maintenance, and anesthesia, among others. THET and the Ministry of Health have also previously worked with the provincial and the district health teams to strengthen the quality of nutritional care for children, those children affected by severe and acute malnutrition. Distinguished ladies and gentlemen, the health sector in Zambia, as the case is in many other African countries, has been impacted by the COVID-19 pandemic. The Zambian health system had to cope with increased COVID cases and related deaths among our people. A number of our cooperating partners have supported the COVID-19 response, bringing the pandemic to manageable levels. Currently, the Ministry of Health is working with its partners on measures to increase COVID vaccinations uptake. This is an effort to attain the target of 70% national vaccination coverage of the eligible population. The national vaccination status is now approximately 60%. I wish, however, to state that some provinces in the country have already achieved the 70% vaccination target, while others have attained 100% coverage. Work has, however, continued at community level to take vaccinations closer to the people. And you may wish to know that vaccines in Zambia are free to all persons over the age of 12. And I want to thank our cooperating partners for making this possible. With regards to the aftermath of the COVID-19 pandemic in Zambia, the country is making significant strides in its efforts to drive macroeconomic recovery. Accordingly, Zambia's cooperating partners have welcomed the government's prioritization of social sector spending, even as it implements economic reforms and thus giving support to the Ministry of Health. As I conclude, I wish to state that the government of the Republic of Zambia, and in particular the Ministry of Health, is looking forward to continued partnership with THET. The Ministry of Health is also looking forward to continued support from the UK government under the new Prime Minister Liz Truss in our effort to improve health outcomes for our people. I thank you.
Thank you, Honourable Minister. Fantastic to have you address us at the conference and to have the examples of partnerships working and contributing and being well aligned to national needs. I have to say, it's lovely to hear words about THET. I sort of often, we know, don't we, that it's the brilliance of the people involved in the partnerships that really matters here. So I say that with great humility. There are so many people that are doing brilliant work in Zambia, and it's not all about THET. A very strong message to the UK government, Richard, that you'll approve of at the end of her speech, which I think we should return to when we have the Q&A. And, you know, celebration of the response to the COVID pandemic, but sobering to think that Zambia is still talking about achieving vaccine coverage in relation to COVID, when countries in the north, including the UK, have achieved that many months before now. But I congratulate the new government of Zambia, and I thank the Honourable Minister for joining us. So we've gone from the global with Richard to the national with Sylvia. Now we turn to the personal, and we turn to Nepal, so quite a different setting with Garnima Mananda, who is a nurse. And this is a more personal perspective, if you like, on the themes of the conference. So Garnima, over to you, please.
Shall I? Good morning and namaste everyone. I am Gaunima Manandar, a registered nurse from Nepal. I'm currently working as a field researcher in Nepal Health Research Council. As a field researcher, what we do is we collect data by visiting to different places in Nepal, and we collect data and we do interviews of both qualitative and quantitative research. We also enter those data in Excel, SPSS, and EB data. After all that, we also translate and transcribe the qualitative interviews. Now, talking about my journey and how it all started, after completing my school, I always wanted to study science. So I completed my +2 in science from Xavier Academy. After that, I wanted to I wanted to do further in medical studies. So I gave my entrance examination and I could make it to Kathmandu University School of Medical Sciences. The 4 years during my bachelor studies was really an amazing journey. That was the first time I stayed away from my home, and it was really I learned and I had a good experience there. Not only the subject matters, but I learned through my experience too. And currently, I'm planning to pursue my Master's of Science in Nursing in a university abroad. Yes, it's possible in my home country as well, but I'm trying to pursue it in a university abroad because it will help me gain more experience, and I will also gain more knowledge and new experience in a new place. So this will not only help me in my course matters, but also in overall. And this is not only for my personal gain, but if I do this my masters in abroad, it may also help me in my help indirectly or indirectly develop the health sector in my country. Talking about health in Nepal, as Nepal is a developing country, we have many challenges and problems in our country. I think that it is all because of lack of education, lack of transportation, and poverty. In my experience, while I was translating a voice record, the interview that took place at Rupandehi Tarai region of Nepal, the interviewee said that she got married at the age of 14 and she had her first child when she was 15. She couldn't vaccinate her child because she couldn't even vaccinate her child because she was far away from her home, working at somewhere far. So she didn't even know where she could vaccinate her child and why is the vaccination important. So I think it is all because of the lack of education and awareness related to health facilities that she couldn't even vaccinate her child. And another experience is when I was a student nurse and working as a in a night shift in maternity ward. What happened is we got a woman. She came to the hospital at around midnight, and At the time, she had delivered her baby on the way. It is all. It is. I think it was because of the lack of transportation. The geographical situation here in Nepal is been a problem, and there is a lack of transportation. So she couldn't even deliver her baby in the hospital. Likewise, another challenge here is that people still, due to the lack of education and awareness regarding the health and health services, many people still believe in traditional healers, and they seek traditional uh, traditional healers instead of going to visiting hospitals or healthcare centers when they are suffering from any kind of diseases. This Because of this reason, they keep on going to the traditional healers for their treatment, and only at the end stage they visit the hospitals or healthcare centers. And at the end stage, we all know that it is quite impossible to recover them from the end stage of any kind of diseases. So I see we can see that there are many challenges and problems still in Nepal. So hopefully, I wish that we can overcome all of these very soon. Here are the projects listed which I have worked on, and talking about them, the burden among caregivers of hemodialysis patients is in National Kidney Center. This was done by me during my master's studies. I chose this topic because I saw that our study conducted in Nepal showed that 49% of the caregivers had moderate to severe burden, with around 17% having severe burden. And in Nepal, very few studies were conducted to assess the burden among caregivers of hemodialysis patients. So this study was intended to explore the burden among the caregivers of hemodialysis patients. And mild to moderate burden was seen among 57% of the total participants. Likewise, moderate to severe burden was seen in 14% of total participants. This was done by using Derek Burden interview scale. And other talking about other projects, I'm currently taking part in Nursing Now Challenge Fellowship Program, which is managed by Tropical Health and Education Trust, delivered by University of Global Health Equity and Ubora Institute, and is funded by Birthday Trust for Nursing, where I have been working on the research topic improving hand of practices among nursing staff of tertiary level hospital in Nepal. We with 6 other nurses. Why we chose this topic is because the 6 of our nurses are working in different fields. So some of us are working in the cardiac centers, while some of us are working in research field, and while other are working in maternity hospital. So we chose this as a topic. And regarding this, previous study from Nepal highlights that despite recognizing the importance of hand of practice in Nepalese healthcare settings, majority of hospitals do not have proper hand of format for nurses, and most of the nurses never had any kind of training related to hand of practices. Likewise, also there is a lack of evidence of standard practice for implementation for communication to deliver quality healthcare in hospitals of Nepal. The study is expected to fill the gap of such evidence and help to develop appropriate initiatives to improve hand of practices in Nepal. This study aims to adopt SBAR tool in Nepalese context and test the adaptability and feasibility of the tools through providing adequate training and support to nursing professionals in tertiary level hospital in Nepal. As we are doing this in different countries, I feel that the global health projects and collaborative works between countries is necessary, and that it is really very helpful and important in nursing community as well. As we can see that this helps to build the relationship and leadership qualities in the nurses, and from different countries, and also we can share all the our experiences and problems in such a global platform with our colleagues worldwide, where we can also provide us with they provide us with solutions and support. This collaborative work not only helps build career of the nurses around the world, but also provides them with knowledge and ideas so that they can provide good health facilities or services. to their parents. They can also provide good services to the patients and also it helps in uplifting the health status of the nation and the world as a whole. Thank you. And at the end, I would like to thank THET and Ubora Institute, along with Bhadesh Trust and all the participants and all the speakers present here today for providing me such a big opportunity to share my words as a keynote speaker. Thank you.
Nima, the thanks is with us. It's lovely of you to thank us, but it's we who thank you for joining us. And someone was celebrating in the chat box the fact that we, have this very personal perspective from a very different country, and that's the point. It's just wonderful to hear how, by being globally connected, you're benefiting as an individual, and how your work is benefiting. I have to praise, by the way, the Burdett Trust, and it's part of the Nursing Now Challenge, which is the successor program, for those of you who don't know, to Nursing Now campaign. Praise the Nursing Now Challenge and Burdett Trust for supporting these fellowships, which is all about empowering individuals, particularly nurses and midwives, to make a difference. So thank you very much for that personal perspective and those insights into the challenges in Nepal. So we're now going to move to the Q&A, and I think I'm going to have to do what I promised, which was to take people's questions first rather than throw my own in. So Richard, the first one is very much about, do you have any advice on how health partnerships can connect outside of the health sector to work more collaboratively on those wider determinants of health and presumably of climate crisis that you were talking about?
No, that's a great question. Thank you. It's not easy, and it's finding a way in. And we've been trying to explore this with some of our work. If I just take one example, we've got a project ongoing at the moment about arboviruses, and how can you eradicate sounds a little bit optimistic, but certainly control the spread of arboviruses, dengue, yellow fever, Zika, and chikungunya, and so on. And the way in that we're trying to work there is to work with city authorities. Over half the world's population lives in cities. Many causes of death are linked to poor city design and urban planning. And so what we're trying to do is to, if we don't work with mayors of cities or city authorities, then we're not going to make any progress on some of those goals for health. So I think what it is, it's trying to go with local levels of governance. And this is where the communities bit becomes important. Oftentimes we talk about what national governments can do, but actually so much local government is more important for shaping local services. And in small countries and big countries alike. So I think going for local, looking to partner with local government of urban authorities is one way forward, in addition to the advocacy at a national level. But I would say our lesson is go to the lowest common denominator of governance. Sounds negative, but you know what I mean. It's the sort of most fundamental unit of governance closest to the community that's responsible across many sectors.
That's great. May I ask a sort of related question, which is 5 years ago, we would have said it's the SDGs. Of course, it's the SDGs. The SDGs are that coherent vision across all the themes in a way
Yeah.
that the SDGs weren't. They're inclusive. They were about change in high-income countries and low-income countries. Why do you no longer mention the SDGs in your answer? Is it because the SDGs are basically dead in the water?
Well, I think that, so I want to believe in the SDGs, but I think the reality is that the pandemic and many of the global crises that we're currently facing have knocked the SDGs sideways. And the idea that we just continue with the SDG framework without taking account of the current global situation seems to me to be living a fairy tale. And rather than living a fairy tale, I think we need to be realistic about what we can do. And we're trying at the moment, we have a piece of work that's trying to look at how the SDGs link together given the global situation. So we're trying to connect the SDG framework with the current world disorder. It's looking at the intersection between health, SDG 3, gender, SDG 5, and peace, SDG 16. And so I don't think that they're completely blown out of the water, Ben, but I think we have to work in a different way around them. We have to recognize that just a linear track of 17 goals, that's not going to work anymore. We've got to work across the goals, and we've got to adapt and be agile given the changing global situation. So, and there are so many immediate crises that we're facing to deal with that thinking ahead to 2030 with some of these abstract targets, I'm not sure. In a world that's relatively calm, you can do that, but we're not living in a calm world at the moment.
Yeah. The next question, thank you, Richard, is about how we can persuade governments in high-income countries to support climate adaptation in low-middle-income countries. So, I suppose in some ways that's a more general question, isn't it? You touched on the UK. The UK isn't the only country, of course, retreating from commitments to 0.7 in
Yeah.
UK. What more insight can you give us into what are the arguments that connect with high-income countries and might persuade them?
Well, I think the key role that we have is to, and I know this is going to sound idealistic, so apologies if this does come across as naive, but given my job at the Lancet, I do genuinely believe this. I do genuinely believe that science and data and evidence used in the right way can be instruments to change society. And it's an old-fashioned belief in the Enlightenment. You know, the Enlightenment happened in the 17th century, not because people wanted to publish papers or write books just for the sake of it or get grants from national academies. Knowledge became important because people realized that knowledge could improve the lives of their fellow human beings. And then over the past 300 years, we sometimes have forgotten that message. And I think it's, you know, our role, the jobs we do, Gaudima's presentation showed this beautifully. And it was a beautiful story of, you know, education from school through college and then into practice. It shows how knowledge embedded in people's lives from an early age leads to social change. So we should be committed to that. And then in the context of climate, it's gathering evidence from communities at the regional and global levels, assembling that in a scientific way, and then presenting it to governments as what I would describe it as an accountability mechanism. You made these promises in Paris. 190 odd nations made these promises in Paris. Are you delivering on your commitments? And if you're not, we need to tell you where you're not succeeding and hold you accountable for that, and then project that to the public. And I think if we do that consistently, you can affect change. I've seen that happen. It happened in the way we manage women's and children's health in the MDG era. From 2003, when the evidence started to be assembled, through to 2015, where you had Ban Ki-moon take women's and children's health as his signature global health initiative, Every Woman, Every Child, the scientific medical community persuaded the UN and other governments to invest literally billions more dollars in women's and children's health. We can do that with climate. We can do that with other domains of global health. So I've seen it happen before. I know we can do it again. The important lesson is, don't wait for governments to act. We have the power if we work together.
I'm going to turn to Galnima in a minute, but I can't resist to follow up with this, Richard, please. You at moments you sound almost nostalgic for a golden era of aid, international aid. I've just been reading a book. It's slightly out of date, but by Jason Hickel, and it's called The Divide, and it sort of stimulates all sorts of thoughts about, I suppose, beyond aid, looking beyond aid. Last night, for example, I was with a can you believe it, a person from the FCDO who was saying, if the UK doesn't contribute to the Global Fund replenishment, which you referred to in your speech, what's the problem with that? Because aren't we moving beyond aid? And when I think of that question that you've just answered, I'm not thinking so much about aid. I'm talking about responsibility, aren't we? It's climate justice as well as climate emergency. So, am I right? Are you coming across as being too nostalgic for a golden era of aid, when in fact we've all moved beyond aid and there are new impulses, if you like, that we should be chasing?
Well, firstly, there are so many elements to what you just said, Ben, but let me try and deal with them one by one. First of all, on the Global Fund, the fact is that the Global Fund's investments, not just in AIDS, TB, and malaria, but in strengthening health systems, from laboratories to clinics, has saved literally tens of millions of people's lives. And I remember sitting in a room in the United Nations when Justine Greening, who was then the International Development Secretary, got up and proudly made her government's commitment. This was David Cameron, of course, as Prime Minister, commitment to over $1 billion for the Global Fund. That multilateral support is British taxpayers' money saving lives in some of the most vulnerable countries in the world. That's something to be proud of, and it's something to be ashamed of that we haven't done that now. So words like aid are very loaded political terms, but it's basically we are transferring money to save lives by buying bed nets, by buying antiretrovirals, and so on. So why don't we want to do that? That seems to me a basic emblem of international solidarity. And if we step back from that, shame on us. Now, it's not that I'm nostalgic about a golden era of aid. What I'm kind of reflecting is remembering a time when we were respectful but engaged international partners, where we wanted to sit around the table with colleagues from all countries and work together to work out answers to difficult questions and demonstrate leadership through the power we have to convene, the power we have to advocate. And we just stopped doing that. Now, the Foreign Office, you know this, and Eldred and I remember when Eldred and I went visiting British embassies in Ethiopia and Ghana. The basic purpose of the British embassy in any country is trade. Trade is the fundamental reason for their existence. And the great thing about DFID was that trade wasn't the purpose of DFID. The purpose of DFID was the stuff that we're talking about. Now that DFID has been folded into the Foreign Office, we've lost that voice. Whatever they say, we've lost that voice. So we have to be that voice. We have to protect that idea of our contribution to be sitting around the table working together to solve these problems. So it's not that I want to look back. It's the fact that I recognize we live in a different time now, and the values that underpin our work, the values that you've talked about of partnership and diversity of voices, those are the values we want to bring back to the table that I fear that we've lost.
Yeah. And confession, I was part of that campaign to secure the 1 billion replenishment commitment from Justine Greening, the UK government, when I ran Stop AIDS. And we don't know. A replenishment commitment may yet be forthcoming. I have no profound knowledge on that. Garnima, Richard is talking a lot about solidarity, and it matters to us, as you know. The power of partnership between individuals and institutions. Can you talk a little bit more about the power you've found in being in conversation with nurses globally, please?
Sorry.
I'm hoping you heard me, Garnima.
Yeah, I heard you. You asked me to talk about nurses.
Yes, and I suppose Richard's expressed it. I feel the excitement of it, but just to talk, if you could talk a little bit more about the value you've got from talking to nurses around the world outside Nepal and how that's benefited you.
Yeah, it sure have. I am currently working as a fellow nurse with along with 8 different countries from Africa and also from Asia. We have been working. We also got different training programs relating to leadership and other quality improvement projects as well, and we got to share different kinds of our views and what we were facing as a daily challenges in our field of work. uh, we had different nurses from different parts of the world. It helped us a lot, and we could also share our problems and challenges there. And they our teachers also helped us to how to overcome over them, and along with our colleagues worldwide.
Yes, thank you so much. Another topic Richard talked about, Galnima, was the workforce crisis. And Richard was focusing on the UK crisis in particular, but we know it's a global crisis. And one of the things that shocked us all recently was to see that the UK is actively recruiting nurses from Nepal to work in the NHS. Have you come across that, and what is your view on that recruitment, please?
Uh, I feel that it's both an advantage. It's also an advantage for Nepalese nurses, as we are getting a chance to like go to some new place, like work in United Kingdom, and also work for health. Uh, uh, Moreover, it's kind of been a controversy these days that uh, as Nepal is a developing country and still we have a lot to develop in health sector, so it's been a controversy that it's better not to bring Nepalese nurses from Nepal to United Kingdom, because still we are lacking health services and healthcare providers here in Nepal. Uh, yeah, but still I still think that it's okay to take some nurses to UK and recruit them there.
And Richard, what do you think? I mean, THET does some thinking on this, trying to, I suppose, find the win-win scenario. So, you know, you can see the NHS both as a service delivery mechanism, but also as a fantastic training ground for
Yeah.
overseas health workers. How is it possible to get a kind of ethical approach to international recruitment?
I mean, I think the trick, Ben, is that the country of origin has to think about the incentives for whether it's nurses, PhD students, doctors, whatever, to come back. You know, and it's up to the country to create those incentives for the individual health worker. Of course, it makes sense, as Ghanima says. You know, the advantage is to go and learn new skills in another country. Who would want to deny any human being those advantages? That's again a fundamental human right to go and seek the best for you and your family. But then the country, instead of, so I don't mean this to sound harsh, but instead of the country government complaining about the brain drain, the answer is the government needs to create incentives. So why should somebody come back? What can you offer that person to come back? Now, if I look at China as an example, a upper middle income country, it offers massive incentives for people to go and get their PhDs in the United States or the United Kingdom, and then to come back to China. I can remember when I've been to Ghana, the government was offering land for doctors to come back and be able to have a plot of land to build their own home. So what are the incentives that are created? This is up to governments to do. So and maybe this is something that again we can help with in partnerships to encourage governments to create those incentives so that their health workers go and get training abroad, but then come back and bring those skills back.
Yes, that's really interesting, and I realize I don't know enough about the China example, but I want to, and I learn more. But I think it's right, isn't it, to acknowledge the push factors, as they say, as well as the pull factors, which isn't to sort of back away from criticizing the UK for not investing enough in training health workers and indeed retaining health workers who have been trained. I think partly, as you said earlier, our challenge in the UK is about retention, isn't it, as much as recruitment?
Absolutely.
I'm very excited to have Ghanima speaking, not least because she is a nurse, and the status of nursing globally seems to me an ongoing issue. It was obviously the theme of the Nursing Now campaign. It continues to be a focus for the Nursing Now Challenge. And last night, for example, we were talking with a group of nurses from Myanmar who have very low status, not just because of the hierarchy, the medical hierarchy, and what knowledge is valued. Richard, perhaps you were talking about that a bit, but also because gender inequality globally. So there's a double, if you like, burden that the nurses often have to face. Before I turn to Ghanima, Richard, what are your thoughts about that issue?
Sorry, just I was looking at the Q&A. So tell me, what was the specific question, Ben?
What I think we're trying to, people like Ghanima, the Nursing Now Challenge, Nursing Now campaign before it, we were trying to break a cycle in terms of the relatively low status that of nursing and midwifery. And I was just wondering what your view on that is.
Yeah. Well, there's not a simple answer to that, but you may remember some years ago, almost a decade ago, we published a report on health professional education, and this was the centenary of Flexner. And the idea was to look at the evolution of not just medical, but nursing and public health training together. And in November this year in Miami, there's a conference, and we're publishing a paper to look at the progress and the future of this. And in a word, if I was going to try and sum it up very, very succinctly, I think the word is interprofessionalism. And that is the idea that when we go into our nursing schools and medical schools, we are trained completely separately. When I was going through my medical training in Birmingham, I didn't see a nurse for my whole 5 years of training other than on the wards working with them. But I was never in a lecture theatre or a seminar with nurses or midwives. Only if you put these schools together, integrate them together so that medical students and nursing students are sitting in the same classroom, having the same curriculum, looking at things from perhaps slightly different perspectives, but working together as a team from the very, very beginning of, day one of medical school or nursing school should be nurses and doctors sitting together because they are the team fundamentally on the front line of delivering clinical care. And if you don't create that value from the very first day of equality between the professions, that interprofessionalism, you're never going to be able to build it. So I think it's fusing together the educational programs of nurses and doctors and midwives so that we develop mutual team building, mutual respect, equality of professional status, and a sort of parity of esteem, this phrase parity of esteem that comes up often. That's the way to do it, I think.
Thank you so much. Garnima, can I give the last word to you? What do you think about what Richard has just said, what I was saying about the status of nursing?
Yes, I feel that in a hospital or in any healthcare setting, it's a teamwork to provide a good quality health care to a patient. And if we start only from our base or from the base level, or while we are getting all our health, whatever we are learning, then I think what Dr. Richard said is just that will just bring some good changes in health sector, and also help in overall development, and also help nurses and as a whole a medical team to work for the better quality of the patients and health overall in the world.
Thank
Thank
you
you.
so much. Thank you so much. And the most sincere thanks to you, Garnima, to you, Richard, for opening our conference in this way, and to the Honourable Sylvia Masebo, of course, as well. It's been a fantastic start. Everything we hoped for, and the big themes and the personal themes have all been touched on. We're in your debt. You'll be glad to know we now move to a break, and after the break, there are a series of breakouts which you can join, and then we continue with a concluding plenary session, bringing the conference to an end around 2 o'clock UK time. Thank you everyone for participating, having a good break, and see you in 15 minutes. Richard,
Thank you, Ben.
thank you.
Lovely to meet you, Garnima. Good luck with your work. Thank you.
Thank you.
Well, friends, welcome to this session entitled Health and Climate Change. What can the global health community do? There are signs of climate breakdown everywhere across the globe, from wildfires in the US and Europe to heat waves in India and Pakistan, followed by the floods. Record-breaking extreme weather events are occurring in every continent and increasing in frequency and intensity. Even in the UK, contrary to earlier scientific projections that temperatures would rise to over 40 degrees centigrade by 2050, this record has already been reached by the summer of 2022, prompting leading climate scientists to warn that the future is already here. But even more than the scale of these events, it is the speed with which global warming, even at the current level of 1 degree C, is resulting in climate chaos, which is causing particular alarm. We're informed that climate breakdown is inevitable, and global leaders acknowledge that they are scared, as avoiding the most catastrophic outcomes is possibly the best we can now do. Climate change is the biggest threat to global public health, as we heard earlier today, that we all face, and all of us in the health community need to work to mitigate or address the impacts of global warming. So against that background, this session will explore the bidirectional correlation between the climate crisis and healthcare, presenting examples of global health projects mitigating or addressing the health impacts of climate change. There are, of course, hundreds of excellent projects in progress worldwide. What we're doing today is to invite a few global health partners and organizations to share their case studies and learning from their projects and programs, and show us practical ways we could all, every one of us in the global health community, act on this climate crisis. So I'm going to begin by inviting our 4 experts to briefly describe their work and follow that with a group discussion. So our first speaker today is Rachel McLean, Green Ward Program Manager, Centre for Sustainable Healthcare. Hello, Rachel. And she's presenting on the principles of sustainable healthcare and 2 case studies, I believe, from your recent Green Ward competition.
I think Marla's frozen. Hi, everyone. Thanks, Marla. Are you able to share the slides? Thank you. Like Marla said, I'm Rachel. Hi, everyone. So I'm the Green Ward Program Manager at the Centre for Sustainable Healthcare. If you could go to the next slide, please. So the Centre for Sustainable Healthcare, or CSH, is a charity that was founded in 2008, and we develop knowledge and resources to support the UK's NHS and other health systems to reach net zero carbon and wider sustainability goals. And we're based in Oxford in the UK. We offer a range of different programs. However, today I'm going to focus on the first 2 on this slide. So looking at sustainability and quality improvement. And then, unfortunately, I'll only have time for one example, Marla, but one example from our Green Ward competition to show SUSQI in practice. If you could go to the next slide, please. So we know that there's a lot that needs to be done to reduce the environmental impacts of healthcare, and we can't achieve net zero targets without changes to how we actually provide clinical care. And so this means we need clinicians to have the knowledge and tools to be able to evaluate their services and then to adapt to new ways of working outside of their traditional boundaries. But at the moment, clinical innovation often takes place quite separately from sustainability efforts. Sorry, if you could press the screen once again. And one more time. Sorry, I thought it would all come up at once. So if sustainability is going to be prioritised among many competing pressures that clinical staff are facing and healthcare systems are facing, we need to learn to consider it as central to the core mission of providing healthcare. And so at CSH, we've asked the question, what if sustainability became part of our quality improvement? Next slide, please. And so this is how our SUSQI, Sustainable Quality Improvement approach, was formed. So SUSQI is an approach that's designed to be used alongside existing quality improvement tools and methodology, and it's to embed sustainability as an accepted domain of quality within healthcare, so to sit alongside other aspects such as patient safety, efficiency of care, or patient-centered care. And in SUSQI, the quality and value of care is assessed through the lens of this triple bottom line at the top of the screen. So this means that the overarching goal is to deliver improved health outcomes for patients and populations while minimizing our environmental harm, adding social value wherever we can, and minimizing financial waste. And so the SUSQI methodology has 4 steps. So setting goals, step 1 would be looking at this kind of overall triple bottom line, like I've mentioned. And then you may move on to step 2, studying the system before you could further refine your goals specifically for your service or a project. If you can go to the next slide, please. And so it's really important to study the system so that we can ensure we're targeting the highest value changes within a service, whether that's looking at an overall service or a particular process or a pathway. And we would do this across the triple bottom line, but I'll just focus on the environmental aspects now. And so this often includes looking at the carbon emissions of healthcare, and the graph on the screen is a breakdown of where the carbon emissions of the NHS in England are attributed to. And so you can see hotspots of carbon on the left-hand side are medical instruments and pharmaceuticals. And what often surprises a lot of people that we work with about this graph is that waste is at the right-hand side, emitting only 0.1% of emissions. And so while I'm sure that many listening today are quite shocked by the amount of waste that we see in healthcare and maybe frustrated by the amount of waste that they generate within their own care, the reason for this is that by the time we're thinking about what to do with an item when we're disposing of it, the majority of emissions attributed to that item have already happened through its production, manufacturing and supply chain. So focusing on reducing and reusing are ways that we can be more impactful. So it's important to note that this graph is kind of a breakdown just across all NHS services within England. If you could go to the next slide, please. So the carbon footprint of specific types of healthcare will differ. And so even for services that provide are within the same specialty, that provide the same types of assessments and treatments, they can have different carbon footprints. And this is a graph which shows the carbon footprint of a specific type of cataract surgery when it's performed in the UK in a hospital in Wales, and when it's performed in Avrand Eye Hospital in India. And so as you can see, the carbon emissions per procedure in India are significantly lower than those in the UK. So Avrand in India generates approximately 6 kilos of CO2 equivalent per operation, which is just 5% of the UK's carbon footprint, which is estimated at 182 kilos of CO2 equivalent per procedure. And both have comparable clinical outcomes. Next slide, please. So thinking about the third step in SSQI, so designing improvement, we use these 4 principles of sustainable clinical practice to help to guide and develop change ideas. So they're listed in order of importance. So number 1 is prevention. So promoting health and preventing disease by tackling causes of illnesses and inequalities. If we can prevent someone from becoming sick in the first place, or prevent kind of exacerbations or prevent the severity of their illness, we can be much more sustainable than if we're needing to treat more serious illnesses. Moving into patient self-care, so empowering patients to take a greater role in managing their own health and healthcare. Lean service delivery, I'll go through an example in a minute. And then low carbon alternatives is prioritizing treatments and technologies with a lower environmental impact. So an example of this might be switching from metered dose inhalers to powder dose inhalers. Next slide, please. So the 4th step would be measuring the impact. So after implementing a change in SSQI, we measure impact across this triple bottom line. So looking at each element of sustainable value, and we're not aiming to arrive at a single figure, but it's rather to better understand the true impact of services and improvements and look at the balance among these factors. Next slide, please. So this is a recent case study from our most recent Green Team competition, which was completed by the Integrated Sexual Health team in Northamptonshire in the UK. So by studying their current HIV pathway, the team identified that many of their patients who were very adherent to their medications and who they would consider to be very stable in terms of their HIV status were attending for appointments and blood tests with the same frequency as HIV patients who were relatively newly diagnosed or considered unstable in terms of their management. So consultants across the county in Northampton met and agreed upon a definition of a very stable patient, and then they formed a new leaner pathway. So for patients who met the criteria of being very stable, they were able to attend annually instead of every 6 months for their medical review and blood test. And so patients were informed of this new pathway, and joint decisions were made between patients and consultants if they were eligible and comfortable to move to annual appointments instead. So this looked at the principles of lean pathways and patient empowerment and self-care. If you go to the next slide, please. In terms of outcomes, so across the year So the team felt that this change was attributable to almost 90% of their cohort. And so by basing their savings on that across the year, they haven't had a full year to be able to implement the project in full yet. They expect savings of almost 26,000 kilos of CO2 equivalent per year, which is equivalent to driving 74,763 miles in an average car. They've saved almost £55,000 a year. And they've had really overwhelmingly positive social feedback. So patients, a lot of the patients in their cohort work 0 hours contract, so they would be losing income to come to these appointments. Patients were paying an average of £9.20 in travel. And from a staff perspective, staff were gaining time for higher value work. So they were gaining back hundreds of hours of appointment slots per year, and then had more time to dedicate this to patients who were actually having difficulty adhering to their treatment, so they could get to the root cause of why those patients were struggling with adhering to their medication and to be able to improve their health as well. Anecdotally, staff noticed that the goal of reaching a very stable status and annual appointments might improve adherence for some patients who needed to attend more frequently, and that's something they plan to measure longer term. And this can be a very powerful public health aim. So having more highly stable patients could actually reduce the frequency of new HIV infections within their local community. Next slide, please. Good. So this was a very, very quick summary and overview, and I've got some resources that I'll share in the chat as well, but I hope that's given you a quick sense of how SUSQI can be used to translate knowledge of sustainability into action within healthcare. Thank you.
Rachel, thank you so much for that enlightening, description of the type of work going on right here. Is this England or across the UK?
It's across the UK. So the example that I just gave in Northampton is in England, but no, we work across the UK and do some international work as well.
That's absolutely fantastic. So thank you so much. Now, from the UK, we move to Bangladesh. A warm welcome to you, Mohan Kumar Mondal. Mohan is Executive Director, Local and Environmental Research affected by salinity intrusion due to climate change. So it's a completely different topic, but let's hear from you, Mohan.
Thank you, Mala, dear Honorable Chair and distinguished speakers and the audience. We are welcoming all of you to my presentation. Basically, I already, our chair said that I am working in an NGO in Southwest Bangladesh. It is a fully charity organization, and we are working in the most saline area of the country. Basically, the southwest coastal region. I think you pass 2-3 slides at a time. Can you please go previous one? No. Next one. You already skipped 2 slides. Anyway. Basically, the southwest coastal region of Bangladesh, one of the climate hotspot of the country, and all of you know that the Bangladesh is very much vulnerable due to climate change. And the southwest coastal region people face a frequent disaster and very precious disaster every year, and a um, lot of loss and damage has been happening every year in the coastal area. That's why the poor people are migrating from the coastal area, and those people who have no ability to who are living here, they are facing some different type of problem. And the groundwater is saline. That's why people have to relate to the surface water for drink. And every year, due to the disaster, the drinking water contaminated with the saline water, and people are bound to drink saline water. And for that causes the women and the community people are facing the hypertension, and the women are facing hypertension and preeclampsia, what causing the miscarriage of the woman. And due to the poverty and the lot of time, and people, the women are staying the salinator huge time, and that's why the people are facing the cervical infection every year, and it is like a disaster right now. And some of them are facing the cervical cancer, and a significant number of women um, have to deduct their cervical organ, and that's the woman, and that the family is family bonding is breaking, and it is a horrible situation in the coastal area. And you will get you will wondering to know that the adolescent guard, they are taking birth control pill to stop the regular menstruation. It's a horrible situation. Next slide, please. And what we are doing in this context, basically we are conducting the primary healthcare camp and gynecological healthcare camp. The primary healthcare camp, we are providing the medical support to the community people, and the gynecological healthcare camp, we are organizing this to screening that kind of patient, and we are providing them the free medicine to all of the, not free medicine, reduced rate medicine, means the 80% discount rate we are giving the medicine to the poor people. And we are also referring the patient to the government hospital and to other places, so that they can get diagnosis services and other facilities if we found any kind of conflict, any kind of complex or special health issues in the coastal area. Next slide, please. And simultaneously, we are also providing a lot of support to the community people, so that uh, uh, they can get the fresh water, drinking water. We are installing different type of technologies, like ponds and filter is one of the community based water treatment technology we are installing in the community. We are installing rainwater harvesting system in the community. We are also installing the managed aquifer research technology in the community, and we are installing biosan filter, and also we are installing the desalinization reverse osmosis system. Till now, we install more than 5,500 technology in the community, so that people can get fresh water. And also we are installing different type of toilet facilities, so that during the disaster they cannot they can use the toilet during the flood and disasters. Next slide, please. And we are also providing the support for the counseling support, and also we are creating health awareness of our community. We are conducting community session on the personal hygiene management, ministerial hygiene management, safe drinking water management, preventive health care in their daily lives, hand washing steps and process, and so on issues. So next slide, please. So, what is our sustainability initiative of our health partnership? The technology what we are using in the community, most of the scientifically proved, and the technology what we are installing in the community are managing the local people, and and they are more capable to troubleshoot the problem of the technology, and they are also taking support from the government services, government department. And we are also engaging the WASH community of Union Parishad. Parishad is a local government, the community level local government agent, and they have the WASH committee, and we are engaging them to our WASH related activities in the field. And the project will continue our WASH related activities, and we will continue our education in the community level. Next slide, please. So we and the community people, they mentioned some way forward, and our recommendation are the more research to identify the health hazard in the coastal area. It is needed an integrated approach to durable solution for drinking water crisis, as it is a very crucial crisis in the coastal area, and floating medical services in the Sundarban Island area, and national and international attention to need to solve the climate crisis what people are facing in the coastal Bangladesh. And also we need a mechanism to assess the loss and damage what people are facing and need to and they are demanding the compensation from the international community. And our what we are trying to do in the future, we are going to launch, we are managing resources to launch a floating hospital in the Sundarban island area. And we are trying to launch a floating water desalination unit in the Sundarban area so that the people from the island area they can get fresh water. And also we are demanding more, we are going to install more water treatment technology in the community so that they can get fresh drinking water, and the woman hardship of the woman can reduce in the community. Next slide, please.
Mohan, may I? You're coming to the end. That's
Yes,
great. Yeah,
this is just from my slide, and if you have any question, I will happy to give you answer later. Thank you.
Mohan, thank you so much for sharing with us your perspective on this truly tragic challenge which Bangladesh is grappling with. We're keen to hear more, especially how you're sharing these, your experiences with other countries, because Bangladesh isn't alone in experiencing this particular problem. So stay with us while we move on to the next presentation from Africa. Aliyu Nuhu Ahmed, a PhD student at the London School of Hygiene and Tropical Medicine research team. Hello, Aliyu. You're here to tell us about your project to recycle plastic waste into reusable lab equipment and leftover food for fuel. Over to you, Aliyu.
Thank you very much. I will share my screen in a minute. Can you see my screen now?
Yes.
Thank you very much. And good morning, everyone. And thank you for inviting me to talk today on a recycling project at the Medical Research Council Unit, the Gambia. So just to give you a little bit of context for my talk today, the MRC unit is in the Gambia and is only second in terms of employment to the Gambian government, and having about 1,000 staff. And so it's a huge community that generates a lot of waste. And prior to this project, the Rewind project, these waste are either being incinerated or dumped in landfills. And so as a team, the Planetary Health Group thought it wise to come up with innovative ways to reinvent the way this waste is being managed and processed in the unit. And so when there was a call for this student challenge competition for carbon emission reduction to celebrate the Queen's Jubilee anniversary, the student from this team and other students at the London School thought it wise to put in for this competition to test some of the ideas that we already have in terms of testing the wheel on some of these initiatives. And so the idea of the project is to reduce carbon emission that is associated with processing and management of this waste through innovative and environmentally friendly way, and also to recycle these waste products into reusable items. And so the specific objectives were to reduce carbon footprint in the MRC unit at Fajara. So the MRC unit in the Gambia has sister units here in the country, about 3 or 4. And just to springboard this project, we're starting from the main campus here at Fajara. And the other objectives are to recycle plastics into reusable products and to produce cooking biogas from organic waste, and also to build capacity on waste segregation and recycling. You can see our incineration facility at the bottom right here, previously when these wastes are being incinerated, especially plastic waste. And this project won the top prize for the Queen's Jubilee Award for the student challenge on carbon emission reduction. So for plastic recycling, we'll be collecting biomedical plastic waste and waste from building, plastic waste from the facility buildings here at the unit. And we will shred these plastics into smaller pieces that would then feed into our 3D printer, where we would melt these plastics directly from the shredded plastic waste into reusable materials. And these materials can also be recycled in the future when there is need to do so. And for the organic waste recycling, we'll be collecting organic waste from our restaurant here at the MRC unit, the Gambia, and also from the facilities within the research unit, and also a sizable quantity of animal dung in communities around. This will form the feedstock for the biodigester, where we use water as the digestion medium. And then the digestion produces a lot of gas, including methane that we are proposing to use for cooking. So we would do some gas purification to make sure that we're getting more of methane than other mixture of, not alongside other mixture of gases. And so we'll collect this gas with a compressor and compress into gas cylinders that would then be used for cooking in our restaurant here at the research unit. But also we would use the slurry, which is the byproduct of the digestion, as fertilizer for landscaping of the unit, and also donate some of these to community gardens. And so this project is novel in its approach. We're using directly shredded plastic waste to produce reusable products from our research facility here. And the two projects, both the plastic recycling project and the biogas production recycling, are integrated. We would be using the plastic recycling plant to produce parts of the biodigester we'll be using to produce the biogas. And also, importantly, this project is student-led in all its activities here in the unit. And we have an existing capacity for 3D printing. We have a mini 3D printer, although prints from synthetic plastics. So the facility, the 3D printer that we'll be using is quite similar in terms of its operational needs. And so the personnel who handles the 3D printer is useful to the team and to the recycling project in general. And we also have a shredding facility here prior even to the arrival of the 3D printer. And that sets a good ground for the project to take off in the unit. And as part of this project, for every successful recycling project, there has to be a solid waste sorting and segregation system. This is one thing we intend to achieve with the recycling project, but also to build capacity and also to engage the community. Previously, the Planetary Health Group at the Medical Research Council in the Gambia has held various programs, including the Planetary Health Conference in 2020, and Climate Change Festival in 2021, where school children had the opportunity to come and present ideas on climate change mitigation ideas. So we would utilize this existing structure and relationship with the community to engage them on this recycling project. The Planetary Health, in collaboration with the Biomed department here, has also recently won a grant for recycling in the unit for both plastics and organic waste, similar to this project. And so these two projects are working hand in hand to complement each other. And the recent awarded project is going to scale this mini project to other units of the MRC in the Gambia and also possibly to other health institutions around. The Planetary Health has a very good existing relationship with various departments in the unit in order to achieve this set objectives. And as part of this project, we would be conducting an impact assessment, and we would be monitoring the recycling waste and measure the amount of carbon that we've been able to reduce for this throughout the lifespan of the project as the project goes on. And these are the designs that we propose to print. Currently, we have all these templates and we are producing mini prototypes that we would then use to produce with our 3D printer that prints from the plastic waste. And finally, I would like to acknowledge Drs. Chris Murray and Rosemary Green for their support for this project, and also the very wonderful and committed team of students we have both at the unit here and at the London School for their commitment and effort to make sure this project kicks off and achieve all the set objectives that is being laid. Importantly, also, I would like to thank the funders, the Royal Anniversary Trust, the London School of Hygiene and Tropical Medicine, and the Medical Research Council. Thank you very much, and I'll be happy to take any questions that you might have later.
Thank you so much, Aliu. And now we move to reflect on a completely different dimension of the climate crisis and health. So I'm going to invite our final speaker today, Dr. John Jamir Benzon Aruta, Senior Lecturer, School of Medicine and Life Sciences, Sunway University, Malaysia, to tell us a little bit about your research, John, on addressing the mental health impact. May I say the mental anguish faced by communities in the midst of the climate crisis, and you're going to be focusing on the Philippines. So over to you, John.
Thank you very much, Mala, for the invitation. For everyone, my name is John. In training, I'm a counseling psychologist. And at some point, I realized that I can actually use my training in psychology to help address the consequences of climate change. And now I'm actively focusing on climate change and mental health nexus, which is perhaps one of the most neglected aspects when we discuss climate change and health. And I don't have slides for this presentation, but let me bring you to the Philippines, where it is often said as the hotspot of of climate change. And uh, I speak as an ordinary citizen from a climate vulnerable country such as the Philippines, and as an environmental psychologist representing the global South and non-Western nations. As an ordinary citizen from a climate vulnerable country, I recall my several experiences of having to face the wrath of typhoons that constantly hit our country. One of my earliest memories is that a strong typhoon severely damaged our grandmother's house, and at some point at the peak of the typhoon, my mother asked us, her children, to kneel down and pray while waiting for the strong wind to blow away our very roof. My mother's reaction is only an example of how climate change can cause psychological distress. And children, as evidence suggests, are especially vulnerable to the mental health impacts of climate change. For example, at an early age, I saw and experienced distress and hopelessness brought about by typhoons in our very family and community. And in my lifetime, I witnessed how typhoons that hit my country become more frequent and intensified. We have very little contribution to greenhouse gas emissions, and yet we are the first to face the severe consequences of climate change. In my country, at least 20 cyclones hit every year, some of which are categorized as super typhoons, killing thousands of people and destroying livelihoods and shelters every year. For example, in 2013, Super Typhoon Haiyan, the strongest typhoon ever recorded, devastated the Philippines, killing at least 6,000 people and damaging homes and livelihoods and displacing thousands of families. On average, a Filipino would face more than 1,000 typhoons in his or her lifetime, which are becoming more intensified due to climate change. Countries like the Philippines have to face these consequences for environmental actions that we are not mainly responsible for. I am also speaking today as an environmental psychologist representing the Global South and non Western nations that are largely neglected in the scientific discussion on climate change and mental health. Yet, research has shown that people in the Global South face the most severe consequences of climate change. For example, emerging evidence shows that Filipino youth are the most climate anxious in the world. They are the most distressed, most worried, and most frustrated, along with other emotions. After listening to my stories, it must be clear to us at this point how and why Filipinos can be highly vulnerable to the mental health effects of climate change. We need to recognize and give justice to those that are vulnerable to climate change, including women, indigenous peoples, children and youth, people with disabilities, those who are socioeconomically deprived, and people in the global south. While people in the rich and developed world continue to enjoy the economic benefits of fossil fuel extraction, people like us in the global south or developing nations continue to suffer from the consequences of fossil fuel extraction in the form of climate change. We hope for further collective action in addressing environmental problems and attention to those who are weak and vulnerable from the brunt of climate change. But one thing that we see in our research is that uh, I always need to emphasize that conversations in the mental health responses to climate change, for example, climate anxiety, eco anxiety, and ecological grief, etc., are not psychological disorders, but they are merely normal responses to the actual threats of climate change. Therefore, the goal is to figure out how to harness these emotions to spark climate action, not only among the youth and general public, but more importantly, among global leaders and policymakers. At the same time, we must not forget that some might develop severe mental health reactions to climate change. Therefore, scientists like us and policymakers must work together to establish mental health infrastructures that accommodate cases related to the mental health effects of climate change. And as I mentioned earlier, the goal is to figure out how to harness these emotions to spark climate action. But what we see in our research is that it appears that it is a very complex issue to resolve. For instance, a multi country study published last week revealed that climate anxiety motivates climate activism only in Western or individualistic countries, but not in many non-Western or collectivistic countries, including the Philippines. This is an active area of research, and we need to learn more about translating climate emotions into action. We need global scientific cooperation that aims to discover and identify country level and community level nuanced patterns of climate emotions and actions. In summary, may this talk serve as a reminder to us all that climate change and its impact on mental health is a global problem that requires scientific approaches that discover the nuances which are necessary for creating policies and innovative solutions. Moreover, may we recognize that climate change and its impact on mental health is a systemic problem as well as a social justice and intergenerational justice concern. There is still hope. Let us all do our best so that the future generations or our great 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 grandchildren will read history books and say that our generation, years 2022 onwards, has made the right decisions, acted urgently, and therefore had been good ancestors to them. I'll stop there. Thank you very much.
John, well, what can I say? Thank you so much for that extremely sobering reflection on the real human impacts, of the climate crisis and stuff that's going on out there, literally now, even as we speak. Well, thank you all so much for these brilliant presentations. What I'm keen to do is to use the remaining part of our session, which is only about 6 minutes now, to seek your wisdom on how we could all get involved in our spheres of influence. So I'm going to quickly say, what is your view of bidirectional learning? Whether it's you, John, sharing those impacts and also some excellent work that you've been doing in the Philippines to get everyone involved in building up emotional resilience, including among the lay people in the community. To you, Rachel, with this wealth of information on how the NHS is calculating its carbon footprint, and yet you know that Aravind does better. So what's your, so you've all got, I'm sure, something you can share with us on what is your take on bidirectional learning, or is it multi-directional learning you're thinking about? And what do you believe the gaps are? And I'm going to give you a minute each to just say which countries you're thinking of, which direction of the learning, and what do you believe the big gaps are. So, who would like to get going? Shall we start with you, John, as the kind of the last speaker, and you've been thinking about these things, I know. So, who are your partners in this learning?
Uh, Thank you, Mala. And I will answer that because my background, for my background as a psychologist, and I think one important
You've
thing
got
that's
30,
happening
you've got 45 seconds.
is that we help people realize the cool benefits of acting for the climate. And for example, we need to help people realize that acting against climate change is also benefiting them, especially in terms of mental health. And from a psychological perspective, there's growing evidence that pointing to the idea that one of the most effective ways to address mental health consequences of climate change is to engage in climate action, which is bi-directional. By engaging in climate action, we are able to express these strong emotions about climate change. And
What's
another
the
important
gap here, John? What do you think what's the barrier? What's stopping things? This kind of strategy being accelerated. Give me just one
I think
example of
from a
a barrier
psychological
which we want
perspective,
to resolve.
sorry, I think from a psychological perspective, this is what we call the cognitive bias psychological distance. That people tend to perceive climate change as something that is distant, something that is not happening right now, but rather would happen in the future, and something that less likely to happen to me and more likely to happen to people, that's not like me or not belonging to my group. And so, from a psychological perspective, the solution is to narrow that distance, and that has implications to
Yeah.
how we create
Thank you,
community.
John. I'm sadly I'm going to stop you there because I think that
Okay, thank you.
dissonance is country to country as well. And I think what you're also suggesting is how the North often thinks, well, this is not going to affect us, perhaps. So, next person I'm going to pose that question to is you, Rachel. So who are you thinking of as your bidirectional partners? One big gap and one big barrier.
If I focus more on NHS staff within the UK that we're working with, I think on an individual level, I've met a lot of staff who they've undertaken a lot of actions to be sustainable in their personal life, but it doesn't necessarily translate to their clinical practice. And whether that's because they feel colleagues won't be interested in talking about sustainability, they're not in a senior position, sustainability is seen as someone else's role, that an expert's needed, or it just feels completely overwhelming to tackle that problem. And they are kind of in a state of eco-anxiety, and that can be quite paralyzing. So that bidirectional and multidirectional learning is so important for opening up to new perspectives and new ways of considering.
Yeah, I'm sorry to being a bit rude and interrupting, but I want to ask you, why haven't we adopted Arvind's practice in the NHS? What's the big gap? I'm going to ask you one word.
I think it's so hard in one word. I think parts of it are, I guess, systems we have in place around risks and safety and kind of being able to deconstruct and look at that in a different way, because the research is there that the clinical outcomes are similar and that it's safe. So there's a lot of that kind of operational side. And then I think from a clinical side, it's a bit of needing to challenge the status quo. So staff are frustrated by the amount of waste they see, but I think it's
Sorry, Rachel, I need to stop you there. We've literally got a minute, so I'm going to ask Aliyu. How far has this got? Has it at least reached all of Africa? Your learning, where are you taking your bidirectional learning, and what's the big gap? One word, please. And you'll be thinking about that, Mohan. So you're going to have the last word on this.
I think one of our biggest objectives for this program is community engagement. We want to engage other health facilities and the community also to export what we are doing in terms of recycling. But I think one of the biggest challenges sister health institutions here in the unit, and especially in Africa, think recycling, in the health system is quite expensive, and you need to set up a different department for it. And maybe not as expensive as its consequences, but it's something that I think
people, okay, so it's false. All right, so it's false perceptions on expense then is one of the big things. Thank you. That's interesting. We have to work on that. Mohan, other countries face this problem. Is Bangladesh sharing its learning with other countries? What's stopping this learning being extended? You've literally got 20 seconds before the session closes.
Thank you for your questions. You know that Bangladesh is pioneer to managing the climate risks and the disaster risks. We are learning from the other countries, and we are also disseminating our learnings, what we are doing in Bangladesh. But the main problem is, I think, the mistrust. Mistrust means we are suffering a lot and we are shouting a lot in the several COPs, but people are do not believing that the people are suffering so much in the coastal area in the Bangladesh. So I think the global community have to be responsible to the poor nations or poor community.
It's
I think
listening.
the trust is a main fact.
Yeah, yeah. Thank you so much, Mohan. Friends,
Thank
that's
you
all
very much.
we've got time for. So I'm going to say a big thank you to our speakers, to you, the audience, and end with a plea that you all accelerate your contribution to climate action starting today. Our future and that of our children depends on it. Thank you so much.
Hello, good morning, everyone. Welcome to a THET Welcome Trust networking session asking the question, what makes for effective and equitable partnerships? Equitable partnerships are essential for all global health partnerships. For decades, there are arguments describing that most partnerships are dominated by the global north. First, Richard, we have four panelists here who will be discussing these questions, and all of them will introduce themselves. And Richard, may I start with you and to discuss that has been striving to achieve equitable health partnerships for 30 years. Can we open this with an introduction from you and an outline of THET's experience in this field? Could you please introduce yourself? Thank you.
Thanks very much, Thin, and hi everyone. My name is Richard Scone James. I'm the head of programs at THET. I have a few set of slides that I'll just share now on the screen. If they haven't come up, please someone shout. But yeah, very delighted to be on this call today, and I'm going to talk a bit about setting the scene for what THET has been doing, trying to help partnerships become effective and equitable. For those of you who are playing Eldred quote bingo this conference, I thought I'd get in there first. So Professor Eldred Parry, our founder, said, if there's mutual trust and a willingness on both sides to learn from each other, a readiness to adapt and a readiness to try new things, then good work will happen. And despite all the work and research we've done since he said this, I do think that this philosophy still holds true in what makes an equitable partnership. All of the work which THET does is based around the partnership model, where partners from the UK and lower middle income countries co-develop programs that address organisational and national priorities. And the aim of all of the projects is sustainable impact and mutual benefit. And you can see there a map of the health partnerships in the UK. We've been facilitating these health partnerships for over 30 years now, growing our understanding of what effective and equitable partnerships look like. And in 2015, we crystallized this learning in our principles of partnership, which lay out what we think the key ingredients are. And so very quickly, we have 9 at the moment. They are: partnerships need to be strategic, harmonized and aligned, effective and sustainable, respectful and reciprocal, organized and accountable, responsible, flexible, committed to joint learning, and committed to gender equality and social inclusion. And we will be adding on a 10th on climate action or climate justice very shortly. We wanted these principles to be a tool for partnerships to develop stronger relationships. So you can access these principles on our website, and when you click on each of the principles, you see a series of hallmarks of good practice. So I've used respectful and reciprocal as an example here, one of our principles, because I think it feeds most into that point around equitable partnerships. But we have a set of 5 hallmarks under this principle. So partners must clearly define roles and equitably share responsibility for planning and implementation. They must collaborate on research opportunities and funding bids. They need to listen to and engage with each other's needs and ideas. They need to respect each other's strengths and weaknesses and engage frankly. And they need to comply with relevant professional codes. And I really believe that 4th one is perhaps the key to all of the principles, in that if you can engage frankly and honestly with your partnership and have those difficult conversations, then everything else flows from there. We then dive into each of those hallmarks and provide tools and guidance to health partnerships to try and adhere to those principles. So I've picked one example out. So defining roles and equitably share responsibility. If you click on that hallmark in our website, you then get a drop-down list of tools. So we have a case study here of an equitable partnership in Zambia and guidance on writing a memorandum of understanding. And that's the case across all the hallmarks and all the principles. So we had our set of principles, and then we thought, okay, well, how are health partnerships going to measure how they're doing against those principles, should they want to? So we developed a self-assessment tool where we took each hallmark, and this tool allows partners to assess how they're doing, score themselves from 0 to 5 against each of the hallmarks. And I've just chosen this one as an example. And what really works well is when individuals fill this out separately, and then they come together as a whole partnership and compare their scores. And obviously you get interesting results in terms of where scores are low, but also where there's disparity in the scores. So where one partner thinks they're doing really well in one thing and the other partner scored at 0, that's where the real interesting conversations start happening. And then from that assessment, we've developed action tools. So this is a very short partnership development action plan where you identify the hallmark you want to work on, what your plan is to address that, and how you're going to go and do that. So we have those principles in place, but we also need our grant management processes in place to enable partners to meet those aspirations. So I've just jotted down a few things that we do at THET to facilitate equitable partnerships through our grant programs. So we've always, as far as I'm aware, required applications to come in for money jointly from the low and middle income country partners and their UK partners. And we've recently changed the rules. So previously, only the UK partner could be the lead contract holder, but now we're allowing the LMIC institution to be the lead contract holder in any grant funding, and obviously the funding flow can have a real impact on power dynamics. It's too soon to see how much impact that has on the equitableness of the relationship, but it'll be interesting to see in a couple of years' time what effect that is having. We are trying to encourage South-South collaboration where possible within the model, and it's a small tweak, but I think an important one. For example, we are increasing the budget allowance for trainer fees. So historically and generally, we still want volunteers to be delivering capacity development activities, but by allowing some funds for trainer fees, it really encourages people from the global south to get engaged in actually being the facilitators there. We're standardizing our volunteer surveys across our programs that captures the benefit to the volunteer themselves in the UK more widely. And in this way, we'll get a really rich set of data on the mutual benefit to the UK. And we've actually just received ethical approval for a wellbeing study, which is a separate survey to volunteers asking how being involved in global health has impacted their sense of well-being in work. So that'll be really interesting to get that data back. And then we're actually just wrapping up a project called the Health Partnership Capacity Development Program, which is slightly different to our usual activity. But this project was focusing on developing the organizational capacity and the relationship between partners rather than on actual project delivery. So we took on board a cohort of 21 small or new health partnerships and looked at how we can support their organizational tools, how we can support their project tools. We looked at new business development, and we also assigned each partnership a mentor from a more established partnership to help them build a more effective and equitable partnership. So that's been a really interesting project for us, and a lot of learning from definitely from THET, but hopefully also the partnerships as well. But inevitably, there's more work to be done for us in this space, and I wanted to have on my final slide a reference to some work that Imperial College and THET carried out a couple of years ago, a research paper, but that Hamdi Issa from Imperial was the lead on. And this is really looking at more of a paradigm shift. So I think previously I've been speaking about a bit of some of the tweaks that we're doing, but they're thinking more of a kind of philosophical shift into how we look at partnerships. And they argue that true equal partnerships require genuine reciprocity. So you can do all the things that I discussed, but it won't be truly equitable if one partner is seen to be giving their expertise to another without an exchange of equivalent value. And it's that equivalent value that's really important to them. So in other words, when one partner is seen to have more resources, there's a risk of the partnership following the kind of traditional dependencies that we're all too familiar with in the aid sector. They suggest 3 ways to try and counter this. So firstly, when setting up a partnership, the needs of the UK partner, they suggest, must also be identified at the same time as those of the LMIC partner, and discussions had about how the LMIC partner can contribute to those needs. And additionally, the UK partner should not automatically take on the coordination or be responsible for administering funding. The second suggestion is that cultural knowledge and soft skills such as communications, leadership, pedagogy should be a secondary priority in terms of how we look at mutual benefit to the UK. That should be a secondary priority to technical knowledge exchange. And they say that this will lead to benefits to the NHS institutionally rather than just the individuals involved. And kind of building on that, they talk about true reciprocity requiring the same type of learning for both partners. So in other words, if technical support is being provided, it should be provided in both directions. Whereas if one partner is providing technical support and they receive soft skills back, there's a risk of that dependency. There's a risk of a sense of subservience or perpetuating otherness, I think, in their words. And thirdly, they suggest consciously and continuously challenging the tendency for UK partners to set the standard for what they call worthy knowledge. So the UK always having this benchmark that others need to reach, and with the goalposts continuously shifting with time. So yeah, some three ideas from this research paper that we might want to explore later in the session. And I want to close on a question really, which is, to what extent is technical knowledge transfer from LMIC institutions to the UK happening at the moment within health partnerships? At THET, we often hear about and have data reported on the other way around. So it'd be really fascinating to hear if those conversations are happening amongst health partnerships. And if we believe in this assumption from this research paper that genuine reciprocity is required, and it has to be technical knowledge reciprocity, is that compatible with traditional donor funding? So is a true equitable health partnership actually compatible with the donor funding that we're used to seeing? Anyway, so I'll leave us on that question that I can't actually answer, but hopefully it might stimulate some thought. Thank you.
Thank you very much, Richard, for the comprehensive presentation about the principles of partnerships, examples, and some stimulating thoughts for helping equitable partnerships. So may I invite now Goran, Dr. Goran Zagana. He is a medical doctor and associate research fellow with the Middle East Research Institute in Iraq, but he's now currently based in Scotland. May I invite Goran? You have been vocal in recent years about the challenges of achieving equitable partnerships between North and South partners. Can you explain more what you think the challenges are? Thank you.
Thank you so much, Stan. Thank you for THET, Ben, Richard, everybody for inviting me to speak on this exciting conference. And let me begin with in the spirit of solidarity that Dr. Tedros mentioned, to express my solidarity to the brave women of Iran and the men who joined them, chanting Zen Zendegi Azadi, which means women, life and freedom. And I also join other colleagues in condemning the pressures that medical colleagues in Iran are under to change death certificates and to kind of conform with the official stories of the Iranian regime for the death of activists. My talk is about my experience with the NHS Scotland's partnership with the Global South, and I am doing that using the critical perspective of the decolonizing global health literature. And I noticed three observations that I can make while looking at the partnership and engaging in these partnerships myself. The first observation, which I call basically barriers for a decolonized global health partnership, is the history, the links to the colonial legacy of these partnerships. We cannot deny that global health has its roots in what's called tropical medicine and also medical missionaries attached to colonial expansions in the colonial era. But you can't only look back, as Richard Horton said. We need to look forward. And currently, we can see that kind of link or that kind of path which was set during the colonial era perpetuated. And one of the way that it is perpetuated and replicated is the dominance of a biomedical model. Richard talked about this in the opening of this session. The dominance of medical specialties and skills in the partnerships. I mean, looking at the partnerships in NHS Scotland's global health work, you can see that most of the skills that are transferred, and I will come to the direction of the transfer, are specialized skills. They are about breast cancer, about endourology, which is one of my favorites, toxicology, specialized, super specialized skills and techniques that colleagues in the global north try to transfer. Well intended, of course, and these are colleagues who spend years learning about these techniques and educating them and training in them, trying to, well intended, trying to transfer it to other contexts. But unfortunately, the transfer or the direction of transfer is unfortunately usually unidirectional, is from the north to the south, with minimal exchange, with minimal reciprocity, and minimal learning from each other. We tried during the pandemic to overcome that kind of unidirectional transfer of skills by inviting colleagues from Kurdistan or from Kenya to our departmental learning about how colleagues in ICUs and acute medicine in Kenya and in Iraq are dealing with that massive influx of patients, COVID patients. And it was a massive learning opportunity. We learned so much from how so-called less developed and low-resource countries deal with the pandemic. So it's not only doom and gloom. There are opportunities for learning from each other. Certainly in Scotland, the rhetoric is changing. There is a call for a shift and a refresh, and there is an honesty about the racism, the structural racism, and what is called the wide gaze that international development, unfortunately, is looking at global health partnership through. But also, there are tripartite partnerships. There are rotations of hosting and chairing of partnerships between Scotland, Zambia, and Malawi, which are experiments that are really encouraging and need to be learned from and replicated perhaps. So again, thank you so much for inviting me to talk, and I'm looking forward to hearing from other colleagues.
Thank you very much, Goran, for this stimulating talk. And also, I'm sure we will be discussing more about these barriers later on. So the third panelist is Professor Asante. Professor Asante is joining us from Ghana. So may you please tell us that you've been in a partnership, notably with the Worldwide Radiology here in the UK. So can you please introduce yourself and share your reflections on what Richard and Goran have talked about so far? Thank you.
Great. Thank you very much, and good morning to all of you. So I am actually presenting from Ghana. I'm an associate professor of medicine at the University of Health and Allied Sciences in Ghana, Ho. And my focus today is to emphasize on our collaboration with Worldwide Radiology. And the focus of this collaboration is essentially on skills transfer and empowering our local colleagues to be able to utilize point-of-care ultrasound in our environment. We tend to have a very skilled access to imaging, and we think point-of-care ultrasound, if you look at one of the key tenets when it comes to universal health coverage, diagnostic is one of the flawed areas in our part of the world, and point-of-care ultrasound is making a lot of difference when it comes to that. So our journey started in 2019, but COVID-19 actually delayed the implementation. We did our first pilot in 2021 with a highly motivated cohort, and so far it's been wonderful. I'll share some pictures later on when I have the opportunity. We had an excellent collaboration with a team from Worldwide Radiology, headed by Dr. Liz Jokers, and we started a very good understanding looking at what the need is and what the partnership is going to be looking forward. So we started with signing an excellent MOU with both partners agreeing on what we really want out of this relationship. And so far, it's been very good. The good thing about this collaboration is that the lead, who is from the UK, actually had a teaching experience in Ghana. He was in Ghana for over 3 or 4 years to teach in a medical school, for which I was once a student. And so he understands the context of our environment. And so far, we've had a very wonderful collaboration, and we're making a lot of progress. Currently, the team is in Ghana, training another cohort. And the focus, those who started the first group, actually some have been selected as trainers. They have been given very good skills, and they are even trainers and joined the team from the UK in training our local group here. And that has really been very wonderful. We have plans in terms of research inbuilt, for which we are all working together for the success of this. We've also opened opportunities for students or candidates who've gone through this training to look at research areas when it comes to point-of-care ultrasound, to make a case for Ghana in terms of the utility, clinical utility of point-of-care ultrasound. In this year's training, we have part of it as a stakeholders meeting, which we are going to engage many authorities in Ghana, letting them know and appreciate this point in terms of point-of-care ultrasound solving our needs when it comes to the skilled distribution of imaging access in Ghana. So far, I think it's been a very wonderful one. We haven't had, should I say, challenges. It's been a very good collaboration with the team. And I think the key plus is that the lead has a lot of experience for our environment. So probably we can be looking at people coming in to see what pertains in particular countries, culturally relevant issues, and that would really enhance collaboration going forward. So thank you very much for giving me the opportunity to share our experience in Ghana with point-of-care ultrasound training of clinicians, increasing coverage when it comes to diagnostics in most rural parts of Ghana. Thank you very much.
Thank you very much, Professor Asante. It is encouraging to hear that the partnership is going well and you have not seen any challenges with the partner, especially with the lead having the background experience of Ghana. Thank you. Last but not least, may I invite Ms. Annalie at Welcome. You have a new strategic plan and are making fresh efforts to define what equitable partnerships mean, particularly in the context of research partnerships. Can you introduce yourself and share your reflections on what Richard Goran and Professor Asante have talked about so far? Thank you.
Thanks so much, Thin, and thanks everyone. It's so interesting to hear the discussion so far. So I'm a strategic partnerships lead at Welcome. I'm responsible for developing relationships with a number of our closest partners, as well as working specifically with our climate and health team to develop and deliver a partnership strategy, and thinking about the coalitions and convenings that needed to catalyse action in that area. But I've got a background in health system strengthening and worked closely with many of the colleagues on the discussion today. So really excited to be here and to really listen and learn from others and to discuss this important topic. So thank you very much for the opportunity. So I think listening to what everyone's been saying today, I think even though perhaps the partnerships that we're thinking about at Wellcome are different in nature. So we're working with our other research partners, with multilateral organizations and advocacy partners, and other funders as well. I think there's so many common themes with what's being talked about. We're really grappling within our team in terms of thinking about how to embed equity, but lots of the same common themes around how can we ensure mutually beneficial partnerships and learning? How can we address some of those power dynamics and thinking about co-development, shared goals, longer term aims, and really the importance of multidisciplinary approaches as well. So just briefly to give you a bit more context of the partnerships work at Wellcome, you'll hear a bit more about this later today with my colleague Megan, who will be speaking later on in the conference today. But this is the first time Wellcome has had a centralized partnerships team at Wellcome. So that's very much recognizing how critical working together and in a partnership with other organizations is going to be in terms of delivering on our new strategy. So the new strategy is a narrower focus for Wellcome. So we have three big global challenge areas, but those challenges disproportionately are those that affect those in the global south and in low middle income countries. And so there's very much a recognition that we really need to shift to working more globally, a real need to diversify those we're partnering with. So our team is very much looking at this through a lens of who are we partnering with and how are we partnering. I think it's fair to say when it comes to research partnerships, a lot of individuals and teams across Wellcome have been thinking about this for a very long time and trying to strengthen our approaches to how we approach research partnerships, not just because, of course, it's the right thing to do, but it's just so critical for research funding to lead to real world change and to have an impact. And so we are very keen to learn with and bring together other organizations that are also on this journey to share and to challenge one another to progress more quickly and in further. So in that context, I just wanted to flag one report that we're looking at that's been recently published is by UKCDR and Essence for Global Health. So UKCDR are a network that aims to build coherence and best practice amongst UK research funders. And Essence on Health Research is an international funders network that focuses on research capacity strengthening. And so this is a good practice report on equitable research partnerships, and it builds on some principles that were developed back in 2017 to really encourage research funders to shift towards more equitable ways of funding. And those principles included areas like prioritizing inclusive agenda setting, continuously strengthening institutional capacity, widening participation by supporting new partnerships, looking beyond the usual suspects, investing in long-term change, and collaborating and learning from others. So this report, I think, builds on those. I think given a lot of research funders had signed up to those principles, I think it's fair to say it wasn't actually necessarily living by those principles. So this report tries to set out more specific steps that organizations can take to make progress in this area. So it lays out 4 interconnected approaches to supporting equitable partnerships, which include understanding and supporting the research partnership ecosystem, shifting attitudes to what constitutes value in research partnerships. The second area is around strengthening and building relationships, so involving fostering mutual respect, developing shared priorities, investing in research management, which is often an area which is a gap, and supporting capacity building. The third area is around allocating resources and budget for partnership building and planning for partnerships when calling for proposals, providing direct funding to LMIC institutions and researchers, and providing follow-on funding and support for research outputs. And then the fourth area is around transforming processes. So really starting to review governance arrangements, policies and processes, IP agreements and that kind of thing to ensure that equity is embedded. So I think this is a really important report that's been published last month, and I really hope to see Wellcome and other funders using this good practice report to really review and challenge and stretch our approaches. But Wellcome's not only a research funder, so I just wanted to very briefly touch on that. We're increasing our policy and advocacy activity and strengthening our government relations and partnerships work to deliver on our new strategy. So we've also been thinking about this equity and how we embed equity into that area of our work. So last year we commissioned a supplier to help us think through that, and they conducted an internal and external consultation. The main findings were that our work, our efforts to engage more diverse stakeholders were really ad hoc. We didn't have systematic mechanisms in place. We were very much engaging the usual suspects in the global north and had very limited engagement with civil society in those communities most affected. And so there were 4 recommendations around centering our work around the people most affected by the health challenge areas, questioning who sets priorities and makes the decisions about the focus and resourcing of our work, analysing power dynamics in operation at every level of decision making, and considering any inequities in our partnerships with other organisations, and to be deliberate in systematically obtaining feedback from partners in the global south and low and middle income countries. And so building on from that, we have initiated a number of activities as teams, mapping our existing relationships so we can identify where the gaps are and start to more actively engage with a diverse set of stakeholders and partners. To explore approaches to bring in external voice, whether that's through external advisory groups, and to really challenge, to bring challenge to our work and consider the different mechanisms that we could do that through. And for us as a strategic partnership team, to really be looking at regional partnerships now. So thinking about whether that's the regional offices of our multilateral partners or funders, or thinking about civil society organisations that are based in the global south. We've just initiated a partnership with an organisation, AMREF, many of you may know, and that's particularly around climate and health advocacy. But we'll be looking to build those strategic partnerships with organisations in the global south over the coming months. Just finally to mention our anti-racism report that was published 2 months ago on Wellcome's progress or lack of progress in this area. And that was difficult reading for many, of course, internally, but it's created a lot of momentum. And many of us internally were glad to see that Wellcome was published that report externally, because I think it importantly now creates the foundation to ensure that the transparency continues in tracking how we deliver on recommendations from that report. And so we as a team are very keen to bring conversations together across Wellcome and with external organisations around our approach to embedding equity into our partnerships work. And so I think for us today is kind of in some ways the start of that process, to start to hear different perspectives, and very keen to understand if there are reflections on how Wellcome and other foundations and donor agencies should be better prioritising equitable partnerships. I'll stop there. Thank you very much.
Thank you very much, Anna. Yeah, so through the 4 speakers, we have heard the common themes and common words such as co-creation, co-development, communication, and also the identifying needs of the partners. And from what Richard has said, especially the 2 things just sprang to my interest is that when we say the mutual learning, the learning and the bringing back to the NHS, and how do we make it more explicit, and how do we collect that data into our system is always a continuous challenge. That is one. And second thing is the what Anna lastly said about the establishing and reviewing the policies and structure and SOPs, and challenging ourselves to make the partnerships co-ownership. And what Richard has given an example, the contract holder to be LMIC, and we will see how that has shifted the partnership more equity on both partnerships, but we will see the results in a couple of years' time. So these are my reflections from your discussions. And looking at the chat, there are no specific questions, but from what you have discussed and heard from each speakers, do you have any final reflections on what have been discussed, and choose only one area that you would emphasize as we move forward to establish equitable partnerships? So shall I invite each of you to give your own reflections for 2 minutes each? So Richard, do you have any reflections, please? Thank you.
Thanks, Lynn. Yeah, delighted to. And just to flag, if we do have time, there are some questions in the Q&A bit of the chat box, but yeah, just if we have time. But in terms of my reflections, I was really interested to read about that, identifying the need in the UK partner, because that's not something I'd really come across before. And I'd be really intrigued to see how many health partnerships do actually do that. So I was interested, because I think if you have those discussions at the start of the partnership, that kind of sets the tone for the rest of the relationship, that this is a truly mutual enterprise. And I was interested by Professor Asante talking about how they identified the need a couple of years ago and set up a memorandum of understanding. And it'd be really interesting to see if they actually discussed and I was checking the Worldwide Radiology website while you were speaking, whether you discussed the needs of the UK staff involved in that partnership. So that would be really great to hear. So yes, for me, the biggest takeaway is that the need of the UK partner, and then trying to think through, and again, interested to hear what Goran would say about what are the politics around LMIC institutions supporting the UK institution with technical knowledge. What challenges arise if you do try to follow that through. But thank you very much. I'll stop there.
Thank you. Shall I invite Goran for your reflections, please?
Yeah, thank you very much. It was very, very insightful and an interesting conversation. I think there was a question by Alex in the chat about what would global health look like in the future. And in 2 minutes, I mean, there is so much about what global health at the moment is and how it should be. But one thing that I would say, this is from the inspiring talks Richard Horton and Gunema was having in the plenary. I think it's a sense of people and communities and societies and civil society and organization at the local level on the ground, engaging in a dialogue and conversation about the problems that we are facing as a species and as a planet today, and engaging in a dialogue which is based in the values of trust and respect, and coming up with solutions that we already think about, and having like academia or governments consolidate those solutions and translate them into concrete action. I think that's probably the way going forward. But there's so many things that we can do as societies and communities to take global health from as it stands now to the future. Thank you.
Thank you very much, Goran. Professor Asante, please.
Yes, so thank you very much for the opportunity to speak on this platform. I was just reflecting on the theme for this conference, which actually talks about reframing health partnerships, diverse voices in a new era. So what it means is that we're looking at a new era, trying to evaluate what has been done in the past and looking forward. For me, I'm going to focus on research capacity strengthening, which tends to be one of the weaknesses when it comes to our part of the world. And I'm going to focus on that as we continue to go through this partnership. I think for a successful partnership, from all the presentations that have been done so far, the key tenet is actually on the mutual trust and respect. And once that is able to be sustained and we keep it and we evaluate and revisit that, I think it allows for a sustainable partnership. I want to say thank you to the team, and we'll keep collaborating and moving forward with you. Thank you very much.
Thank you very much. That is very useful. And Anna, before your reflection, there's one question in the chat for you. I wonder what your thoughts are on having a more formal framework to ensure that communities are included within partnerships and projects. So perhaps giving your reflections together, you can respond to this question as well. Thank you.
Thank you, Finn. Yeah, I noticed that's a really good question. It's definitely something we'd really like to see. I think that's it's something we're starting to see in a number of projects where there's been initiatives to bring in perhaps CSOs based in the Global South to conduct a consultation with other CSOs for us particularly in our pandemic preparedness work. So it's something we're starting to see, but I think we would like to have a more formal framework for that. So actually, we are in conversation with we have a centralized equity, diversity and inclusion team who've actually commissioned a review into how Welcome can work with external advisory kind of groups and functions to look at the best practice approaches to doing that. I think there are some opportunities, complexities and challenges that we just need to be aware of and make sure we're following a best practice approach in doing that. So once we have the findings from that, and I hope that's something that we can also share with other organisations as well to inform the way others engage more in a more formal way with communities and with experts from different parts of the world. So yes, I think that's definitely something we're very keen to do and to do quite quickly as well. In terms of reflections, it's been a really interesting discussion. Again, coming back to the point I made, I think there's so much we can learn and there's so many common themes that run across, but also recognizing that within your international health partnerships work, you also think about research partnerships specifically as well. So I think that's an area that we could look at specifically. And I think we'd be really keen to kind of look more closely at the principles work that you've done and think about how we could apply that to the work that we do. I think the really important points around history and our role in decolonizing global health and recognizing that the history and the power dynamics is going to be really, really critical. So yeah, it's been a really interesting discussion and very keen to kind of learn and continue to engage in dialogue with others as we go on this journey together.
Thank you very much, Anna, for your reflection. I don't think there are any more questions in the chat box. I think there is one message for Richard, but I hope you have picked that up. And would you like to respond or not? Yeah.
I've responded in the chat. Yeah, thanks, Lynn. Yeah.
Okay, thank you very much. This has been a really interesting discussion, and I'm sure that there will be ongoing discussions about this as well. For me, my take-home message is that what Professor Asante has said, the mutual trust and the continue building on the relationship is the key thing for making sure that the partnerships are equitable and the power dynamics are solved. But of course, that has to be backed up with the the solid framework and also policies and structures such as the one that Richard has laid out for us will help us implementing the ideas into practices so that all partnerships can be equitable in the future, and also the mutual learning aspect, which we continue to challenge what kind of learning that brings back into NHS and how we can make sure that that learning bit is also met, not just for the LMIC partners. So with that, I would like to conclude this session and thank you all so much for participating in this panel. And thank you.
Thank you.
Thank you. Bye.
Thanks
Thank you very much. Thank you.
Well, a very warm welcome to everyone to this session on scale. I think it's going to be a really exciting 45 minutes. My name's Andy Leather. I'm a professor of global health and surgery at King's. And scale is new to me. So I'm going to learn, as you're all going to learn. I heard about scale last week. And I've been working in health partnerships for about 25 years. So if this is a new innovation and a new way of doing health partnerships, I want to know about it. And part of the objective of this session is to raise awareness so that we're all aware of scale and the potential opportunities to use the scale model in our own partnerships. Scale, of course, stands for Strengthening Health Workforce Capacity through Global Learning. So we're going to divide this into three parts. We're first of all going to hear from Dr. John Paul Bagala from Uganda. He's an obstetrician in Uganda and the scale lead. And we're going to hear from Tom Bashford, who's a consultant anaesthetist here in the UK in Cambridge and an assistant professor in healthcare systems in Cambridge. So they're going to raise our awareness and so that we're all on the same page. And that'll be for about 15 minutes, and then we'll move into a panel discussion. And we've got a wonderful panel with 4 or 5 additional colleagues who I'll introduce a little later. You've obviously got their bios on the agenda. And we'll have a good 25 minutes of discussion. And in that part of the session, we're really wanting to tease out whether there's any modifications to the scale model that could improve it further. And also other opportunities for expanding scale model outside its current use, as I understand it, principally in Uganda and other East African countries. And then we'll have a wrap up for 5 minutes at the end. So sit tight and do think about questions that you might want to raise. So as you're listening to this first session, I would strongly suggest you reflect on your own partnership working. And if you're not using scale, as I'm not, think about, well, is this an important addition to our own way of working? And as I say, jot down some questions for the panelists. So with that introduction, comments over to you, John Paul and Tom. And I think you've got some slides to share. So do introduce yourselves and tell us all about the scale model. Thank you.
Yes, thank you very much indeed, Andrew, for that wonderful introduction. I'm very cautious that we have 15 minutes, so I'll take only 5 minutes of that time, and I'll leave the 10 minutes to my colleague, Tom. The SCALE program, as you've rightly mentioned, Strengthening Health Workforce Capacity through Global Learning, is a global engagement model which builds health workforce capacity in subspecialty and specialty areas of need identified at government, regional, institution, and peer-to-peer level. And the program facilitates or enables partnerships to be established. The model aims to address shortages in skills and knowledge in 4 core clinical areas: critical care, emergency medicine, maternal-fetal medicine, and neonatology. The program has 3 mutually beneficial levels. One is virtual clinical learning and knowledge sharing, oversees fellowship opportunities for NHS staff. That is the second mutually beneficial level. And the third mutually beneficial level is global health placement of clinicians from East Africa to work within the NHS. It's an HEE, Health Education England program, and the way we approach the program is that we first initiate government-to-government discussions which may culminate in establishing a government-to-government health alliance, like we've done for Uganda and Kenya. And then we undertake a scoping exercise to identify which clinical subspecialty or specialty areas of mutual interest for us to roll out within the program, And then we further go ahead to set up the program and then proceed to its delivery. The core goal is basically to strengthen health workforce capacity in the identified clinical specialty and subspecialty areas, which I've earlier mentioned. And the first objective is to have the virtual aspect developed, which can sustainably enable clinicians within East Africa engage with clinicians within the NHS. And then secondly, to offer opportunities for fellowships for clinicians from the NHS within East Africa. And then the third is global placement of clinicians from East Africa within the NHS. So we have different delivery phases, and the first one still goes along the three core objectives that I've mentioned. And the virtual learning basically looks at establishment of scale sites, and as we shall hear from the panelists, we have quite a number of institutions from the NHS and higher education institutions from the UK that are leading the implementation of the program, but also we have some programs, some projects that are laid by the Royal Colleges, like the Royal College of Emergency Medicine, as we shall hear from one of the panelists. And then secondly, we proceed and establish an action learning set. And the composition of the action learning set is that you have clinicians from East Africa, from any of the countries within East Africa. I think majority of our panelists are implementing the program in Uganda. So much of the reference will be made at Uganda, but the program runs in Kenya, Tanzania, and Rwanda. But from each of the countries, we identify clinicians and they are put in an action learning set with clinicians within the NHS. And then we identify clinical leads from both countries who guide the development of the clinical learning schedules, and those clinical learning schedules guide the virtual clinical grand rounds, as our panelists will share. And then the other component is on the professional placement. And this is where the virtual aspect enables the peer-to-peer engagements, the reorientation of the clinicians before they get into the physical movements or the physical placement. So the virtual component has appeared to be very, very powerful towards the entire operations of the program, that by the time the clinicians go into the physical movements, there is already that appreciation and feel on how clinical care is practiced in either of the geographical regions. And what we basically look at from the physical movements in either directions is to enable the fellows undertake those short, intermediate, long-term attachments, obtain where possible subspecialty qualifications or fellowships, and also be able to participate in bilateral research. So what as I wrap up to hand over to Tom, we've managed over the past 1 year that the program has been running actively, because we started active rollout of the program in November 2021, and that's when we started the virtual sessions. But we've so far reached out to 2,300 clinicians. We've managed to carry out over 20 joint virtual clinical grand rounds between the NHS and Uganda. We've identified 10 regional centers of clinical excellence within East Africa. Uganda has 6, and then the others are split across the other East African countries. 10 scale sites, and these are institutions from within the NHS and higher education institutions from England that are implementing the program. We've established as part of this 5 local maternity and neonatal systems within Uganda as one of the model that is enabling us link local maternity and neonatal systems that are established within East Africa with the corresponding LMNSs within the UK. And we have 4 East African countries that we are covering so far. In the past 1 year, 3 scale emergency fellows have been identified, and Andrew will speak more to this. And also my colleagues from Cambridge will speak more to the scale critical care fellows that will be undertaking the attachment. And we've so far held 1 scale conference, and 1 will be happening in London on 26th of April next year. So I'll end at this, and I'll hand over to Tom. Tom, over to you.
Thanks, JP. That's great. I've been rapidly changing slides as things have progressed to try and keep us all to time. So let me quickly share my screen, and hopefully that is now a full screen, which you can see. So to try and put a lot of that overview that JP has just given us into the context of an active partnership, I'm going to very quickly introduce you to how Scale Critical Care is working from within Cambridge Global Health Partnerships. Cambridge Global Health Partnerships are a body that sit across the Cambridge Biomedical campus to coordinate a lot of our global health activities, both within the NHS Trust and the university. And it's essentially on their behalf that I'm speaking. So the first thing to say, as JP's intimated, that this is all based in Uganda, and for us in Cambridge, that then forms part of a much wider partnership that's been running for a long time between Cambridge and various partners in Uganda, and that's both a clinical and an academic partnership with quite a lot of crosstalk between those two institutions. We have existent maternal neonatal health, antimicrobial stewardship, paediatric cancer, and now Scale Critical Care partnerships. And so Scale came at a time, and very sort of fortuitously, at a point where it nicely complemented other work that we were doing in Uganda. And crucially, what that sort of looks like is an action research partnership where we have lots of different bodies and bodies of people within sort of Cambridge and Uganda collaborating both in parallel and in series. But there's a great role for the Uganda-UK Health Alliance to help oversee and coordinate those activities to make sure that we pull in the same direction. There are mutually beneficial areas of overlap. And this is just a subset of all of the different organisations and kind of interests that might be involved in the Cambridge-Uganda partnership. So teasing out specifically Scale Critical Care, I think some of the really interesting things from a health partnerships model is that this is very much a top-down driven process, whereby we begin with MOUs at the ministerial level between HEE, University of Cambridge, Cambridge Global Health Partnerships, the NHS Trust, and all of our Ugandan partners. And for me, that's quite a different model in some ways that for many other health partnerships I've been involved with, it started off at the clinical level and then grown up gradually to get more and more endorsement, whereas this comes in with ministerial blessing essentially from the outset because it's seen as such a area of local priority. And I think that local ownership and that local leadership is massively important. So the fact that we have the minister driving and overseeing this program from Uganda lends weight to all the rest of our grassroots efforts. But that's not to take anything away from the grassroots relationships that grow up both around and because of the Scale Critical Care program. And I think, like all health partnerships, they live or die by those friendships and relationships that you make with colleagues around the world. And I would say that in Scale Critical Care, that's no exception. As JP has laid out, essentially, there are three broad elements to the Scale program. The distance learning aspect we have initially interpreted through virtual grand rounds, which have been incredibly well attended. We are looking at already UK placements for Ugandan staff, and actually that has been one of the, I won't want to use the word easier, but it's been one of the more straightforward aspects to manage. And then our latter phase, we'll start looking at Ugandan placements for UK staff, then going out to Uganda. I've mentioned a research program specifically, and I won't go into that in great detail, but almost as cross-cutting themes of these elements, there's research, there's quality improvement, and there's clinical delivery. And so again, those are all things which explicitly Scale looks to endorse. And the research angle is something which the Permanent Secretary for Health, Diana Atwine, in Uganda is very, very keen to support. And a lot of the work that's been done between Cambridge and Uganda over the last few years explicitly helps support the development of clinical research and health systems research across the partnership. So the virtual grand rounds have now been running for several months. They're attended by upwards of 100 critical care consultants, registrars, interested parties from across Uganda and the UK. The way that works is that we have coordinated clinical cases between a Ugandan lead and a UK lead to identify themed cases from our two critical care units. And what that tries to draw out are similar problems we might face clinically, but the different ways in which they are addressed across the two contexts. And it's very much focused on bidirectional learning. So there's no senior partner here. No one is instructing another setting on how this could be done. It's very much learning from each other's experience and trying to understand what the common problems are and what our differential solutions to those two things are. In terms of placing Ugandan clinicians within the NHS workforce, from a medical point of view, that is very, very well supported by the existing medical training initiative. And already we've been able to start recruiting and placing Ugandan doctors within the Cambridge health ecosystem. crucially with critical care, as I'm sure will be apparent to many of you who've worked in there clinically, nursing is an absolutely fundamental aspect of that. And the same structures do not exist at a national level to help us get nurses from Uganda to the UK to start developing their critical care nursing capacity. So our lead practice development nurse, Lisa Enoch, has become a really, really strong part of the partnership. And she's developing local procedures at Cambridge University hospitals that will allow us to bring Ugandan nurses across, get them registered to work clinically, put them through a formal program of education and accreditation in the UK before returning to Uganda to complete their critical care diploma. And so that's a really, really fundamental part of the partnership, which we are working hard to develop. And very conscious of time, there's an enormous research potential across this partnership. These are two of my colleagues walking out of the Institute for Infectious Diseases Institute, IDI, in Kampala, which is hosted by the University of Makerere. Uganda has a really, really evolved research system, which we're really keen to both support and work alongside to pull out specific aspects of critical care research, both looking at clinical problems, but also systems problems. And so we see that as a way of knitting a lot of the clinical side of scale together and drawing in an even greater range of experience to kind of crack difficult problems. So I have whistled through those slides. I'm looking at my clock and I've overrun by 2 minutes, but hopefully that's recoverable. So thank you very much. I'll hand you back to Andy for the chairing of the next part of the session. Or I will try to. Have we lost Andy? I think we might have done. JP, you can still hear me, okay?
Yes, I can hear you quite well, but I think we've lost Andy.
Okay. Louise, do you want to take in to continue chairing, or do you want JP or I to pick up the reins?
Oh, yes, great. Not sure if everyone can hear and see me. Yeah, thank you, and apologies for that. And I'm Louise McGrath, the Director of Programmes at THET, and a great shame that we've lost Andy, who's chairing the session so effectively so far, and obviously such a key representative of the health partnership community. But yes, the next section is having a question and answer session with some of the representatives from the scale partnerships, like Tom himself, but with others from the Cambridge partnership, to really understand what this partnership means to them, how it differs.
Louise, I'm back.
Oh,
I'm back.
Fantastic.
I don't know what went on there, folks.
Oh, sorry. Oh,
I
back
could hear
to you
you
then,
and see
Andy.
you all, but I couldn't put my video on.
Oh,
anyway,
apologies. Back to you. Thank you.
So, yeah, it's brilliant that we can now be joined by a few other colleagues. So, Rowan Bernstein is a consultant anaesthetist in Cambridge. Welcome, Rowan. Kathy Burgoyne is a paediatrician in Uganda. Welcome, Kathy. Andrew Fryer is from the Royal College of Emergency Medicine. So warm welcome to you, Andrew. And I think we haven't got Dr. Priska Casito yet, but we're hoping Priska might join. So yes, let's move on to this next session. And I'm going to start off with some questions, but I really do then want to open it up to a Q&A. So do get ready with your own questions. And anyone can answer these questions. So how does this model of partnership compare to other forms of partnership working that you've all been involved in? I've been thinking about this for the last sort of a day or two. I think there are some fundamental differences, but I'd love to obviously hear your views. So who wants to go first? Just start speaking. Rowan.
So I'm happy to start. JP and Tom in some ways have sort of talked about this quite well, but for me, I'm a jobbing clinician on the ground. Although I'm Cambridge, I don't do a huge amount of research. I'll just put that one out there, but I do see the research bit being important. Well, it's actually fundamental, but really the key bit, I think, is the whole way this whole program started. So having all the governmental approval, THET, the Royal College of Anaesthetists, Royal College of Emergency, all the really big organisations were all there given to us on a plate, whereas previously I've had to go out and engage all those organisations, because it's been a much more ground up approach to how you set your partnership up. So having that come at the start of the project has been a phenomenal advantage. And it's my initial sort of reluctance or anxiety was that it mean that the program that had been set up, because there had been extensive discussions with the Ugandan teams around how this project would run, would put a significant degree of inflexibility into it. But in fact, it's been really flexible. So they came to us and we could look at it and say, actually, this will work better at these times or so forth. And we've worked between the two to actually start to hit the ground running, but also to be able to be realistic about how we could run the different elements. But having that top-down, I don't like top-down stuff as a rule, but actually for once it's been really, really useful. And then the other thing which wasn't teased out so much is, for me, the aim of this project is around building workforce capacity. And often when certainly in my previous partnership, it was very focused on education, which of course is fundamental to building healthcare workforce capacity. But it's just having that slightly more nuanced approach to how we're looking at this that is really has been quite fundamental to how we've all been thinking about how to make the project run. I'm happy for other people to come in because I can talk till the end of 15 minutes if you want, but I won't.
Can I just come back to you on just a point you made, Rowan? You talked about the educational training, and are you implying that there's now greater alignment with clinical care delivery? And so we're not just doing educational training, but there's a real focus on quality of care and clinical.
Yeah, absolutely. And it's and right from the start, we and I guess we've got experience anyway from running critical care within another partnership, so we've got a feel for what may or may not work. But yeah, it's around really being very focused, because quite a good example, for instance, is how we have worked through how to deliver the nursing element of this, because initially we wanted to bring people we wanted to run a whole lot of courses and so forth, and there's stuff we just have to go and do in country because the nursing workforce is so small that actually you would completely destabilise the critical care nursing workforce even further if you started bringing nurses over here. And in fact, it's the same from the medical workforce. So it's really, really focusing as you deliver your education on how you can embed that, enhance the workforce and keep the workforce working effectively simultaneously. I guess in the way we do in the UK, but because of the distance, it's a bit more complicated. And obviously using remote stuff to do it, but there's some in-person stuff you have to use.
Okay. Andrew, I think you wanted to come in.
Yeah, I was going to say for the two things that came to mind from my side is, one, when we started the discussions and the conversations, when JP put us in touch with Ministry of Health, with the other partners, it was a time when we couldn't travel. So it's started off with a sort of virtual component that has led it. And I think that's come at a time when that's something that's becoming very common. It's been used through the pandemic. And there's a lot of people who are very receptive to that sort of approach. The second component I'd say is that rather than saying from an institution to institution partnership, from one sort of UK trust to a hospital in Uganda, it's looking at a sort of nation approach, supporting the Ministry of Health at the first level and their plans for each particular speciality, but then looking at the other regional referral hospitals. So it's got a focus which isn't initially based on one institution to another, but starting off perhaps with that, but then looking to see how that can be expanded and replicated, and then also bringing in the UK partners as well, and the Ugandan partners across those sort of areas identified has been very useful in sort of making sure everyone's in the room right at the beginning, rather than, as Dr. Rowan said, trying to search for that as you go on and learn.
Interesting. I mean, it would be fascinating when we open it up a little bit to see if there's any concern about that top-down approach amongst the health partnership movement. Yeah, I could say more on that myself, but I'll bring in Kathy. Do you want to come in, Kathy, on this first?
Yeah, great. I think lots of you have already said everything that needs to be said, but I just really wanted to add on that. So I do run an NGO, and I do work across Eastern Uganda with that NGO from a bottom-up approach, but I've since been involved in the top-down approach from scale and neonatology. And I think there's many benefits, as you've already alluded to, but one of the key benefits, I think, is the accreditation of anything that's done, the accreditation of any training, of any courses, getting CPD points, whereas many NGOs run training, but it's not recognized nationally. It can be, but there's a long pathway, as we've alluded to. And the same with taking attachments overseas. Many NGOs, international NGOs, they take people on attachments and they give them training, but trying to get that training accredited is very, very challenging. So by taking that top-down approach, which is very different to what I've been involved in before, really, it doesn't make the training any better, but it makes it a lot more useful in country for the people who have undertaken that training, right through from the clinical grand rounds, getting CME accreditation, up to the clinical attachments in the UK.
Tom,
Yeah,
you've all said positive so far about this different approach. Tom,
I'm afraid I'm not going to buck the trend. The other thing that I have really been struck by with Scale has been essentially the foresight of HEE to put genuine financial resource into the Ugandan side to create the Secretariat and the Ugandan UK Health Alliance within the ministry. I think one of the things which is challenging about a lot of health partnerships is that the admin, the strategic side is often UK driven, because that's where the back office staff are, that's where the funding lies. If they're THET funded partnerships, it's often the UK institution holding the money. And so it unbalances the partnership from the beginning. And one of the things I've liked so much about Scale is that JP and Henry and the team in Uganda are holding all of the reins of this process. This is a Ugandan process, which we have been approached and contracted in to help them deliver for Uganda. And I think that sets exactly the right tone from the outset. So that's a much better balanced partnership from the get-go. And then in terms of what that means for coordination locally, for bringing in other partners, for balancing, for managing politics, both within the UK partners and between the UK and Uganda, that's both healthier and more efficient. And so for me, that has been the enormous good sense of HEE to say, look, we're going to fund this at a Ugandan level, and Uganda are going to own and run this program. And that, I think, is transformational.
Rowan, bring you in.
I'll come in and buck the trend ever so slightly. I actually entirely agree with Tom. And that's really important. I think there are two elements. One, which hasn't eventuated at all, and maybe it won't, but there is still always this niggling angst about governments changing and leader changing, and on both sides, that may have an impact on this. But I guess that's the same. That's part of the uncertainties of any partnership program. And the other bit of it is that one of the spin-offs or the consequences of it being so locally owned in Uganda is, and the funding and all the admin project management type stuff going into the Uganda side has been, there has been none really put in on the UK side. And I think that we're going to struggle with that. And I've got various ideas around how that could be addressed, but perhaps a slightly more novel way than we have done previously. But that is, I think that could potentially be an issue, and is potentially a rate limiting step to how, or rate limiter to how these programs really evolve. And there's, yeah, you could address it. There's way, it needs money, obviously, but, and different ways of thinking, but yeah.
Would this have been possible if it wasn't for the Ugandan Health Workforce Alliance being in place? And would it be possible if it you know, did it rely on a Ministry of Health really having clarity about what they saw as the clinical priorities in country? You know, is it possible to really do something similar in some countries where ministries are far weaker, where there's constant change of ministry personnel, as you've alluded to, Rowan, and where there isn't the clarity necessarily in ministry about what needs to be done? The clarity sits with the senior clinicians and nurses and senior doctors. So it sounds wonderful, this, but I'm deliberately being provocative here. I hope the chair's allowed to be there. I won't get asked back if it's not right. But is there concern that this isn't translatable in other settings?
Yes, but I think by doing it in these nations where it is possible, everyone is interested. My inbox is continually having people from various of the nations, and actually in country as well for other reasons. So I think this is getting it started in places like Uganda, Kenya, where it is entirely possible to do this because other bits of the infrastructure there, is absolutely the way forward for other countries. I mean, my vision is that we see something like this at least running out over the whole of East Africa, and that certainly seems to be my sense that it's starting, because I know other scale programs are starting. I think there was somebody on the link about Kenya. I know we've had Rwanda on the discussions with and so forth.
Great, thanks. I'm going to move on to the second question. What have been some of the challenges? It sounds as though it's gone incredibly smoothly, but can you just, I don't mind who, but someone just point out some of the challenges? That would be very helpful.
I can start if you like. So we got 6 centres of neonatal excellence here in Uganda, which is great. But I think even within those 6 centres, there's a huge difference. I can only speak for neonatology, but a huge difference in the provision of neonatal care between those 6 centres. So the stage that we're at now in scale neonatology is the virtual grand rounds, of which we've now had 3. They've been really, really successful, really well attended. Everyone's learned a lot. And we've really tried to encourage not just the doctors to come, but also physician assistants, clinicians, midwives, and nurses. But I think the challenge for me is that change. You know, are we trying to bring all the Ugandan neonatal units up to the level of the top neonatal unit in Uganda, or are we trying to narrow that gap between the north to south inequality? I think sometimes in those grand rounds, there's a fair number of attendees, whether they're doctors or midwives or nurses, just thinking, this is so beyond our reach. How are we ever going to get there when listening to particularly the south to north, you know? And even then when they've received a fantastic education, and we've had the discussion both from the Ugandan and the UK side, I think then we have those following blocks of, you know, how am I going to implement this? Now I know what to do, but how do I actually get there? So if we use an example maybe of something like an exchange transfusion, maybe that's quite new and novel as a treatment for jaundice to people in Uganda. But even once they've attended the grand round and they know about it as an intervention, they don't have the clinical skills, they don't have the confidence or the competence to implement it because they haven't had the attachment. And also, as many of us are aware, we don't have the human resources to be able to deliver an intervention like an exchange transfusion. So I think it's great that we have these grand rounds and we can learn from each other. But I think the clinical placements of the neonatal fellows as we move forward are going to be vital. But even more so, I'm really interested to hear about clinical care, how you're beginning to involve the nurses. Many of our neonatal units here in Uganda are run by nurses and midwives. 1 doctor, for example, here in Mbali, we have 1 doctor and 8 midwives and 2 physician assistants. If we don't strengthen the capacity at the bottom and we just strengthen at the top, those changes won't hold and they won't be sustainable. So I think scale neonatology, we've discussed it, and I believe we can follow closely behind critical care. But I think for me, we mustn't just focus on the doctors, and even within the grand rounds, we need to bring in those other cadres of health workers, allied health professionals. Thank you.
We're having our first nurse-led grand round today.
Yeah.
Fantastic. And any other comments from Andrew or John Paul, Tom, about, you know, challenges or how it might be improved, how the model will be improved? Andrew.
I'll take one regarding challenges. The sort of the stage of emergency medicine in Uganda is still very young. There's only 4 that have currently gone through the MED program. There's a number coming through this year, and then there are plans to expand. However, we are keen to have a sort of learn and return component to the program, but we don't want to do that at a stage where it's perhaps potentially detrimental to the impressive work that has already gone on in Uganda. So I think it's about ensuring that there's, you know, a critical mass, that the environment's right, and then finding and ensuring that if we do have people going on the NTI scheme, it's part of that government-to-government agreement that there's a post for them to return to when they finish their time in the UK. So it's about managing that, which is quite a sort of complex thing to work out and envisage about what point that is right. But I think we're cautious and keen to make sure if we do that, it's appropriate and of use to the long-term aims of the ministry.
Thanks for that. Kathy, one comment, and then we'll open it up to some of the questions that are coming in the chat.
Great. I totally agree with Andrew. I just wanted to respond that it
Kathy,
also works the other.
Oh,
yeah. I just wanted to respond to Andrew, and I agree with what he said. Can you hear me, Andy? Yeah, great. It works the other way in that we need to make sure that the people who are trained in the UK come back to provide the healthcare here in Uganda. So we've had some great conversations with Ministry of Health, with Scale Neonatology, to try and give those fellowships to people that are in the government system in Uganda, and then to make sure that they come back to the government system in Uganda, and ways that we can go about that. We don't have a solution yet, but we all know about the brain drain. And if we give these people extra skills, and rightly so, they might go to private healthcare, or they might step across the border to Kenya. So it's all about maintaining that skilled workforce once we've achieved it. So yeah, both ways. Thank you.
Thanks for that, Kathy. So let's move it out to the floor, and we've got a question here from Emily Deed, who's a specialist registrar, I think, and she's saying yes, South-South partnerships would be a fantastic shift to focus on much more, where centres of excellence in particular are recognised. And any further comments about that? I mean, Scale is HEE, it's UK to East Africa, but are there a lot of opportunities for it to work slightly differently, or is the focus all the UK link? Tom.
So, I mean, I think JP can speak to this better than I, but essentially the way that we have understood Scale to be rolling out across East Africa, especially HEE's vision, is that Uganda will be a local hub to triangulate a range of South-South partnerships in terms of the Scale programme. I think that UK link will remain useful, but essentially we represent a resource to be used by JP and his team as they see as is most effective. I can see that in the future, what will happen is that the Ugandan hubs of expertise will become the leaders in their locality to help similar units across the different clinical domains to develop capacity. So the future vision is that we become less relevant as that local expertise becomes more relevant. But I suspect that's a long-term vision rather than something that you would, it would be nice to imagine that you'd work towards that very quickly, but realistically, I'd be surprised. But JP, you have a better insight than me.
Yeah, thank you very much indeed, Tom. As you've rightly mentioned, the program is being rolled out in East Africa. Of course, it started with Uganda. In less than a year, it has been extended to Kenya. Now, Tanzania and Rwanda coming on board. Health Education England has a geographical focus on Asia and the Caribbean. And quite a number of low and middle income countries have expressed interest in the program. So it's a sort of product that a number of governments are coming in and saying that we think this answers our question on how we can build specialty and subspecialty practice. Aside the North-South, we are looking at how we can also have within the East African region, how Uganda can learn from Kenya and how Kenya can learn from Uganda as well. And the same, we are trying to see how we can nurture those geographical learning aspects within Asia and the Caribbean as well. So it's part of the architecture of the program to nurture North-South and also South-South collaborations. But of course, the other piece to add is that the program has started with 4 subspecialty areas. Of course, there is room in the intermediate and long term to expand to other clinical areas based on asks from governments. Take, for instance, the Kenyan government has asked that they need oncology to be included in the program. But of course, we have to look at some sort of similarity in terms of rollout of the program across the different countries that the program is being implemented for easy coordination, but also as we engage the strategic partners. Hopefully I've answered the question, Andy.
Yeah, no, that's really helpful, John Paul. Just a question about resources and written resources, website resources. I think someone's put something up here. But disseminating any information about Scale, I think is going to be important. I think this sort of session is going to be useful. It's recorded. We better share it. But are there where would you go? Where would you advise people to go to find out more information on disseminating the learning from Scale? Anyone want to comment?
So I'll just make a go, and then my other colleagues on the panel add. But we've uploaded quite a number of resources on the Uganda UK Health Alliance website. The program also, quite a number of institutions that are implementing the program within the UK have uploaded some bits and pieces of their particular projects that they are leading on their respective websites. But of course, it goes without mentioning that this is an organically evolving program where we've kept learning, we've kept back and forth. The discussions about the program started in 2019, although the actual implementation started in 2021. So you can see the time that it took us just having back and forth discussions and doing some bit of learning on paper before we started the implementation. But there are resources out there, and we're very, very happy to share. Any other person could add? Tom, Rowan, Andrew?
I think you've covered that well enough, JP. I'm not sure I have much to add.
And just a comment from me, which I've been wanting to raise, this is very much a clinical focus. This is, and of course, health partnerships are quite broad, and the focus isn't always entirely clinical care, and it isn't always entirely as this is. So much of our own work actually at King's is in the higher education space. It's away actually from the clinical area. Or it's creating an enabling environment for service delivery. Is there an opportunity for Scale to pick up on some non-clinical themes, more health system strengthening themes, if you will? Be interested in any comments on that. And then I need to wrap up quickly. Tom.
So to that end, very quickly, Andy, I think what happens with all these partnerships, and most people will probably recognise, is that things become fractal very quickly and squirrel off into a million different things. But so, for example, as we started to look at the distance learning programme, although the Grand Rounds are part of it, that then very quickly starts to become focused on the critical care training curriculum and how that can be written and then how that can be supported. That then very quickly, because of the way Ugandan critical care training is structured, takes you from the university level, which each university tends to write its own critical care training curriculum, towards working with the Association of Anaesthetists of Uganda to make a national curriculum, and that feeds quite quickly up to Connector and how you make that a regionally ratified critical care training curriculum. And so before you know it, exactly as you say, you're operating a lot at the curriculum development higher education space. I think the interesting thing for these health partnerships is where you choose to draw a line and say, well, okay, we can't do that, or where you say, actually, we can just draw more people in and support it. And I think that's probably why I suspect the different scale programs will start with that same core package and evolve into quite different beasts as different expertise and different interests explore different areas of the landscape.
That's really helpful. That's really, really well articulated. Thanks for that, Tom. I don't know whether, Louise, you could put in how much more time we've got, whether there's any, but that'd be good as I enter wrapping up stage. We've got 2 minutes. Excellent. Good. Well, look, I think this has been really interesting. I'm impressed and I'm more convinced, and clearly there's a lot of interest in this new model of health partnerships. And I think really what you've all been articulating so effectively is some of the benefits of this engagement, this sort of top-down approach, which I and probably many others actually have been slightly resistant to over many years. But the value of that top-down approach and the ownership, the national ownership, and the fact that there's a really careful discussion about what should the priorities be, what should the priority focus be, and that's been interesting. And then how that can really help busy clinicians, I think, as Rowan was pointing out, to sort of just get on and do the bit that they're good at and interested in, and perhaps not be caught up in some of the administrative and some of the sort of management aspects of health partnership working, which should be so onerous for busy NHS clinicians. And the reciprocity and the benefit from both sides has been articulated really clearly. And then I think finally, for me, those comments you just made, Tom, about the fact that it can lead, move away from the clinical coalface, as it were, which after all is probably the most important part of health partnership work, and can lead to systems thinking and the development of systems. And the very fact that the initial discussion has happened at a high level facilitates that that further engagement and scale up of the health system aspects of what is essentially a really strong clinical interchange between health professionals. So I think it's been a really useful session. I hope everyone who, I think we've had over 50 on the call, so I hope you've learned a lot and can go away and reflect on it and do reflect on whether your own partnerships can in some way use this model in the future. And I'm really, really grateful to our panelists for their time and for really articulating so clearly the benefits of the scale model. And finally, I think, well done HEE, because clearly they've pioneered something which is, I think, agile and is something which could be a really useful model, not necessarily to replace the traditional way of running things, but certainly to complement the way health partnerships have been and are being run, over recent years. So I think, well, with that, I'll draw this session to a close. Thank you again so much to our speakers, to our panelists, and I hope you enjoy the rest of the conference. Thanks very much.
Good afternoon and good evening, depending on where you are. Happy to welcome you to the 2022 annual conference for THET, and a big pleasure to have you participate in this session where we are going to look at stigmatization of healthcare workers. It's our hope that through this discussion, we are going to explore the experiences of individual healthcare workers who have worked on different health conditions to share with us the experience of stigma. I know oftentimes when we hear stigma, we think of the patient facing the stigma. Rarely do we think of the healthcare workers being the victim of stigmatization. So it's our hope that this discussion is going to kickstart a long discussion on what needs to be done to address this otherwise hidden topic, and yet very vital, because healthcare workers are a scarce resource, and we need to ensure that as part of their well-being, we address this issue of stigma. So we are going to run this session. We'll start off by having 4 different speakers sharing their personal experiences. They are all healthcare workers coming from different countries and continents, and it's our hope that this is going to give us a global perspective at what stigma looks like from the health workers' perspective. And then after that, we shall get into a discussion, a panel discussion with each of these speakers, and thereafter we shall wrap up the session with a speaker from WHO. So without further ado, I wish to invite Dr. Musa Sechikubo from Uganda. Musa is an obstetrician who works with Makerere University, where he's a senior lecturer and the current head of department for the Department of Obstetrics and Gynecology. And he's also the Ugandan lead for the Kawempe Hospital, Cambridge Hospital's health partnerships. So looking forward to hearing you share your experience. Over to you, Dr. Musa.
Good afternoon, everyone. I'm happy to attend the THET conference. And my name's Dr. Musa Sechikubo, and I'm an obstetrician gynecologist at Makerere University. I also work with Cambridge Makerere collaboration on infection prevention and control in Women's Hospital and Kawempe National Referral Hospital. In working in an environment with resource-limited capabilities, a number of resource limitations affecting our service delivery, and how does that carry you through being attached somehow to COVID in a hospital setting? I think to understand it better, you would look at it from the perspective of being a champion and also looking after the patients that suffer from COVID. What does that mean to the rest of the people you live with in the hospital environment, in the community where you live, and even your family? How would that impact on the people in those three spheres? I'll start with the sphere of the hospital environment. In the hospital environment, we are thought to be extremely knowledgeable about how COVID is transmitted, what can we do, what can we prevent, how do we prevent ourselves from getting infected. But that was not completely true because we're also learning in the process. But we became a focus of attention and the focus of prevention. And we became role models in prevention of COVID in a hospital setting. Fortunately, as time went by, other infrastructure were put in place, like hand washing facilities at the main entrance of the hospital, hand washing facilities at the entrances of the wards. And the focus shifted a bit from the champions to include many other people in a hospital setting. So one of the stigma which is associated with being a champion is you are too knowledgeable about the disease, which may not be correct. Of course, you also try your level best to get as much information as possible. And the other challenge is that you might actually be having the disease, that you are infected with COVID. So that's why you feel you are not scared looking after patients with COVID or suspected to have COVID. That is in the hospital setting. The second sphere where I would feel the discrimination or people feeling jittery about where you work and how you do your work is the community where you live. Because that is the time where there was restricted movement of persons in the country. There were a lot of lockdowns. And then they saw this one individual who always went to work and came back from work. And by default, you're working on COVID patients, therefore you're likely to have contracted COVID. So your neighbors would look at you with suspicion. You would definitely not want to travel in public means because that would increase your risk of getting infected or infecting others if you're infected. And people really would avoid coming to your family. And if anyone member in your family fell ill, they would say, well, he caused it himself. He caused the disaster to strike in his house because he goes every morning, he leaves his house to go and work on COVID patients and then come back and infect his people. The third sphere where you would feel a bit of stigma is your family, which you live with. They definitely know where you work, and they definitely know that you are at high risk of contracting COVID. And when you come back home, you are torn apart. What do I do to protect the people who are around me? Do I sanitize? Do I spray myself with alcohol at the main gate, at the entrance of the house or at the entrance of the bedroom? What do I do? Do I first eat? Do I first bathe from somewhere else? So it became like a real stigma, like people would not want to get too close, even in your family unit, too close to you, thinking that you are likely to be infectious, and if you are infectious, then you're likely to cause them danger. So those are the main three spheres where someone would feel eventually people understood that yes, COVID is a pandemic and it is a serious illness, but there are those who are at high risk of getting a serious infection of COVID, and there are those who are likely to suffer complications from COVID. So we triaged amongst the healthcare team the people who are at high risk of contracting or even getting complications out of COVID had lesser exposure. So the stigma was somehow ameliorated, because eventually, even those who would think that you are the COVID expert or the COVID immune, who would not die from it, those people would come. We reached a point that everyone was in one way or another exposed. So it's not like one was more likely to die or contract it, but everyone was exposed. And the stigma went down. And then everyone encouraged each other to wash their hands, observe the SOPs of infection prevention in a hospital setting. And from there on, infection prevention and control in a hospital setting has become a mainstream idea, and everyone is really zealous on implementing it in our hospital setting. I hope that sets the stage for a discussion. If there are questions that one needs to ask, I will be happy to respond to those. Thank you very much.
Thank you very much, Dr. Musa, for that thought-provoking sharing you've given us about your experience. And maybe important to say is, given that Dr. Musa works in a maternity hospital, even with the lockdowns, the services were needed. So he has flagged off how they were really at the front line. So I have the pleasure to introduce our next speaker, who is Dr. S.K. Ahamadu, a public health practitioner and champion in Nigeria for the UK Royal College of Obstetricians and Gynecologists Making Abortion Safe program. We are looking forward to hearing your experience as a champion for abortion, something that draws a lot of attention, oftentimes negative attention. So over to you, Dr. Eske.
My name is Dr. Sikirat Kailani Amadu. I work in Nigeria. I had worked in IPAS Nigeria as a technical lead in the health system units, and I led the training of all cadre of healthcare workers, including doctors, nurses, midwives, and other lower cadre caregivers. I collaborated with federal and state government officials, as well as donors and implementing partners. And we interacted with professional associations, religious and traditional leaders, as well as many women groups. My stigma experiences, as an IPAS staff, we were generally referred to as the abortion people or the terminators. And at conferences, participants avoided our breakout sessions. If we have abstracts to present or we have some experiences to share, if we want participants, workshop participants to attend our breakout sessions, they avoided us. And in order to ensure that we still pass our information, we resorted to making our presentations at plenary sessions. Plenary sessions are quite expensive, but they were giving us value for money in the sense that it is at such sessions that majority, the largest group of workshop participants attend, and you have all cadre of very important people who need to hear what you need to pass. So that was how we were able to resolve the issue of people avoiding IPAS presentations. When there was a change in the governance in the United States and there was the return of the gag rule, some implementing partners also avoided us. They don't want to be seen together with us, especially at meetings and at events. And some of these partners were actually people that we had collaborated with. Some are even, we are together as consortium partners, but because they were in the process of getting funding from the US, they didn't want to be associated with abortion or IPAS. And that for me was quite troubling. I have also experienced transitory or episodic stigma at religious functions when the clergy asserts the anti-abortion rhetorics. I was convinced, but once in a while I ask myself, is it true? Am I doing the wrong thing? But I was convinced that I was helping the women. I was preventing harm. I was helping them to not to harm themselves or to kill themselves from unsafe abortion. And other supports came my way among our peers, those of us that are working together and that believe that our mission was on good, that we're helping women, we weren't doing anything wrong. We were able to talk to ourselves and to ensure that we keep up the good work. Then when the training on values clarification exercises started, that was a very big support for me. And I had also conducted values clarification exercises for many group of people. I've conducted for the clergy, I've conducted for the lawyers and judges, for police, for nurses, for doctors, for women groups. At the beginning of the exercises, they talk tough, they repeat the murder rhetorics of abortion and all manner of very derogatory terms. But towards the end of the values clarifications, when we give examples that they can relate with, many of them we were able to buy them to our own side, and many of them actually even become abortion champions. Thank you very much.
Thank you very much, Dr. Eske, for sharing with us that experience. We are looking forward to further engagement with you during the discussion. Our next speaker is Dr. Suleiman Lakol. He's an infectious disease physician from Connaught Hospital in Freetown, Sierra Leone. Over to you, Dr. Lakol.
Good morning or good afternoon, depending on wherever you are in the globe, distinguished ladies and gentlemen. My name is Suleiman Lako. I'm a lecturer in the Division of Infectious Diseases in the University of Sierra Leone. I'm here to share my experience on stigma associated with the Ebola outbreak in West Africa. West African nations of Guinea, Liberia, and Sierra Leone, which together constitutes what we refer to as the Mano River Union countries, had an outbreak of Ebola in 2014 that ended in 2016. This is the largest Ebola outbreak to date. More than 28,000 people were actually infected during this Ebola outbreak, and there were about 12,000 deaths. Of these three countries had the largest share of these infections and these deaths that occurred. In Sierra Leone, this is the first Ebola outbreak, and probably the same for Guinea as well as Liberia. This is the largest and this death that occurred. But even with this, there was a conspiracy theory at the beginning of the outbreak. Many people do not believe the existence of the outbreak. They felt Ebola was an exchange for money by the government. And there are so many other conspiracy theories. But when one of the doctor who was providing services at the Lassa Fever Center died, that's the time people believed that indeed Ebola is in existence. Now, despite the fact that the death of healthcare workers created awareness and make the population to take Ebola serious, but it also had its consequences on us as healthcare workers. Was one, it served as a source of stigma, and two, it also served as a source for isolation of healthcare workers. And the two types of stigma that has been characterized, we are all experienced by us healthcare workers. One, the enacted stigma, which is what happened externally, what people think about us, that resulted in social isolation and other forms of injustice. Those are experienced by us. But also there was internalized stigma. If you are a healthcare worker working in an Ebola center, there is that fear that I should also not go very close to family members, especially children, your close family members, because you don't want to cause an infection if you are infected. So because of this, there was this both enacted stigma, which is caused, which the public thinks about us, and internalized stigma. That is something that has to do with our own thinking. I was in Nigeria when the outbreak started, but of course I have to decide to come home. But even when I was outside in Nigeria, the name Sierra Leone was synonymous to Ebola. They say you're a Sierra Leonean. Even people that knew that you have not been out of Nigeria for a considerable period of time, they stigmatized. Similarly, when we took the decision to come back, we have to pass through North Africa because flights ceased to come to Sierra Leone. And in North Africa, to be specific, in Casablanca, we spent 8 to 12 hours in isolation before finally we are flown to Freetown. So the stigma is not just for those people that are in country, but even externally, as long as you are attributed to Sierra Leone. And when I started working in one of the Ebola facilities in the outskirts of Freetown, these two types of stigma were experienced by me. I can say this situation is not only for healthcare workers, but the populace themselves, more especially those people that suffer from the Ebola epidemic, the survivors. This is a study by one of our colleagues, James et al., and he found out that the stigma index was very high among Ebola survivors. And like the stigma that I, as a healthcare worker, suffered, the Ebola survivors also suffer both enacted and internalized stigma. But many of them actually has internalized stigma. We are a small society, and whatever happens, it has a tendency to affect each and every individual. And we know ourselves very well. So that also serves as a way to perpetuate the level of stigma that occurred during the Ebola outbreak. I want to thank you. This is an experience from the healthcare workers in West Africa. Thank you.
Thank you very much, Dr. Lako, for that sharing with us that experience. And indeed, we are looking forward to the discussion so that we delve into some more details. So I have the pleasure to invite Francis Fernando, the Director of Nursing and Quality at the East London NHS Foundation Trust of UK and the Founding Director of Filipino Nurses Association UK. Francis, over to you.
Thank you very
Thank you.
much, Shiba, and good morning, good afternoon, and good evening to all our visitors who are watching the conference today. Thank you for inviting me to briefly discuss my leadership and advocacy project for Filipino nurses in the UK, specifically around COVID-19, around the COVID-19 pandemic. Next slide, please. So, as we all know, the Filipino healthcare workers in the UK had a disproportionate number of deaths due to COVID-19. Most of them were frontline workers and mostly working in the National Health Services as staff nurses and other care workers. There were also some who died in the care sector. They were called heroes and angels, but actually they were just doing their jobs looking after people. So this tribute was created by a nurse from Dubai who's also a Filipino nurse called Nathan. He's an artist as well, and as a testimony, as a tribute to our fallen comrades, he uh, beautifully depicted their images when they were alive. There were 82 Filipino nurses and healthcare workers who died in the UK due to COVID-19, more than double of those who died in the Philippines. And the stigma that their families suffered even up until now is quite horrendous. They were denied of the benefits that are due to them. uh, there are some even colleagues whose ashes are still here in the UK and are being prevented from being flown back to their families in the Philippines. Next slide, please. So before the Filipino Nurses Association UK was established in the midst of the pandemic in July 2020, and because of the high proportion of deaths from my colleagues, I wrote to the UK Parliament Committee for Women's and Equalities in 2020. At the same time, I also raised my concerns to the Chief Nursing Officer for England, Dame Ruth May, and to the Rush National Director, then Yvonne Coghill. I even managed to raise around £17,000, and also my other colleagues raised additional £5,000 to help the bereaved families during these very difficult times. There wasn't any Filipino Nurses Association during that time. There were more than 200 local Filipino communities across the UK, not only in England, but also in Scotland, Wales, and Northern Ireland. But there's no national voice, national representation for Filipino nurses. So I had to engage with national healthcare leaders through different media, and also raised my awareness through the British media, through BBC and Channel 4, because we felt during that time, even during the pandemic, that we were not heard and seen. And it's very lucky that I've been a member of Ruth May's senior advisory group, strategic advisory group, since 2012, and I used that opportunity to erase the stigma attached to Filipino nurses, because most people think that we're also Chinese. And as we know, the virus started from a province in China. Next slide, please. So now there were wide changes implemented. So we can be seen now at different regional, national, and system-wide discussions and committees representing Filipino nurses in the UK. We are also supporting other internationally educated nurses in the UK, not only those from the Philippines, but also those from India, from Sub-Sahara Africa, and from different parts of Asia. We work closely with Equalities for Black Nurses and also with the Philippine Embassy in London to ensure that the welfare and rights of Filipino nurses are continued to be respected, and that we are developed, and that we are supported in our roles, or mostly our colleagues are working in the front line, and even their families are stigmatized due to the COVID that they had whilst working in the front line. But the good news is we are now working with different organizations and having those regular dialogues. I've even managed to start an initiative, national initiative, to progress the careers of my Filipino colleagues, whose 20% had job promotions recently. And as you can see there, 170 of them had mentors and coaches. Next slide, please. So these are just some of the impact of the advocacy work of the Filipino Nurses Association UK. If I could just read one of them, particularly from Leah, who was pregnant in the middle of a pandemic, and she was stigmatized and being put in the front line to look after patients with COVID-19. And during that time in 2020, we didn't know what the impact is the COVID-19 is going to have on pregnant women, and also in their impact on their babies. So she said in here, I would like to take this opportunity to thank you for your continued support and never-ending advocate to the Filipino nursing community. You're one of your people who is always available to help us. I'm forever grateful for the support during my pregnancy and for introducing me to people who helped me during the COVID-19 pandemic. So I basically referred her to the Chief Midwifery Officer for England, Professor Jacqueline Dunkley Bent, who agreed with me that she should not be working in the front line while she was 28 weeks pregnant. Next slide, please. And thank you for this fantastic opportunity to Dr. Keith Chalmers, Shiba, and the rest of the team. If I could just finish my brief talk with a quote from our national hero, Dr. Jose Rizal. It is a useless life that is not consecrated to a great ideal. It is like a stone wasted on the field without becoming a part of any edifice. And that's the Filipino Nurses Association UK's legacy and vision. Thank you all very much for listening.
Thank you very much, Francis, for that very good presentation, thought-provoking, and it's amazing to see the progress you've made, how you were able to turn around the negativity and get something positive out of it. And kudos for, that testimony that you just read out, I think speaks to the value of standing with each other, peer-to-peer support. So we are going into the discussion session now. We have about 15 minutes for us to discuss further. So just to kickstart, we've had experiences from COVID. We had a chance to hear from Dr. Musa, who shared the Ugandan experience, and Francis shared the UK experience for COVID. Dr. Eskia shared with us abortion, her experience in Nigeria as an abortion advocate. And then we've had from Dr. Lako sharing his experience of Ebola, the West African Ebola outbreak, which really gripped the world with fear. I think it kind of laid the stage for COVID. I think if we hadn't had the Ebola outbreak, then it would have been worse when COVID hit. So I think we have interesting perspectives, and I think the question that rings around is, given these different experiences and faces of discrimination that you've talked about, I think it would be good for us to. It's a pity Dr. Musa is not here. He has a question on how do you overcome similar challenges during the Ebola outbreak. We are having an Ebola outbreak right now in Uganda. We pray it doesn't, grow up in numbers or doesn't cross the borders. For now, it has been contained. So we shall shelve that question, but maybe this is something I can put to the rest of you, reframe it and say, given these experiences you've had, how do we turn around the lessons that we are learning, these experiences, into a body of knowledge, a set of recommendations on how we prepare ourselves as health workers to handle stigma with the disease conditions we are dealing with, And even there are others that we are yet to appear that are going to bring stigma with it. So what are some of the things we pick from here? So I'll ask maybe Dr. Eske, you can go first.
Yeah, good morning, everyone. The way we were able to get around the stigma, like I mentioned, is through support, individual supports among the advocates, as well as the organizations that we're working with. And it is quite rewarding in the sense that even for all our trainings, clinical trainings, especially for providers, the first one day, or if the training is meant for just 2 or 3 days, then half a day is meant for values clarification. Values clarification is very important for the provider himself, as well as the way that the client is treated. When the values are clarified, the clients are treated with respect and with empathy. So I've seen that the tool, the values clarification tool on itself, is very useful, and it helps in also improving the quality of care. Because when the provider's value is not clarified, or when the provider does not have empathy, the quality of care to the client is also affected. I didn't get the second part of your question.
Thank you. I think you've been able to address how you've been able to turn around the stigma, and I think the lesson that you're sharing with us to share with the rest of the healthcare workers is you appeal to people's value system, because I think stigma comes from that point of being judged from the lens you're wearing. And what you do with your values exercise, what I seem to pick, is you make them remove that lens and you give them a new lens to view things from a different perspective. And once they get that lens, then there's empathy and they are able to understand where you're coming from, and then that deals away with the stigma. So thank you, Dr. Eske, for that. Francis, kindly share your perspective on that.
Thank you, Shiba. I totally agree with what the good doctor said about values and empathy in managing stigma, but I will also add around education and raising awareness amongst our leaders and amongst healthcare professionals, and even amongst our patients and service users that we look after. And also there is something about role modeling of healthcare leaders, and trying to, as you said, Shiba, trying to change the perspective of how people look at, for example, Ebola and the coronavirus that we had, the pandemic that we just had recently, which the world has not seen before. So yeah, so it's around raising awareness, role modeling, education, and ensuring that we are informing policymakers of evidence-based and research out there with regards to these viruses that caused this pandemic.
Okay. Thank you very much for that. I think I wish, since we only have 2 speakers present, I wish to invite our next speaker, Asia, to come in and share with us, and then we can have a further discussion. We'll have an opportunity, the minutes saved, we can discuss. So Asia is the technical officer for community and social interventions at WHO Geneva under the quality of care team. We are looking forward to your discussion, your contribution. Over to you, Asia.
Thank you very much, Shiva. And I'm hoping to stimulate more discussion and thinking, particularly around how we can begin to weave together the excellent sharing of stories from all the speakers so far. Because I think one of the issues that we need to address is that dealing with stigma, there's no magic bullet. It's systemic, and so therefore the solutions have to be systemic. And a number of those solutions have already been touched upon by the previous speakers. My own background has been in community activism and community development. I'm Somali of origin, and I grew up in the UK, and so I recognize a number of my compatriots in the audience as well. And I think this sense of connection and community, which also was raised, is really at the heart of understanding how exclusion works, because stigma is an extreme form of alienation and disconnection. And I really appreciated Dr. Suleiman when he talked about stigma that is enacted and stigma that is internalized. And so what we have is a fracturing of connection, and we have the absence of presence, and we have fear, judgment, and shame sometimes, because when we internalize stigma, we have a sense of feeling less than ourselves, of being vulnerable and exposed. And the examples that have been given by the previous panelists has sort of unpacked the stigmatization of certain diseases, but also stigmatization of health workers as well, as they're going about caring for others and doing their jobs. I count myself as a health worker because I also trained as a nurse in Sheffield in the UK. And my work at WHO, particularly in the emergencies department, where I was working in supporting multidisciplinary rapid response teams deal with infectious disease outbreaks, really informed my own thinking of the importance of the relationship between frontline providers and the patients and the communities and the families that they're trying to serve. I spent 5 months in Sierra Leone working alongside ministries of health and village chiefs and Ebola survivors during the 2014-15 Ebola outbreak, really sort of getting this sense of what is that relationship look like? And I think in the health sector, we are very good at diagnosing problems and saying, here is what's wrong with you and with what we're trying to do. But the solutions, we tend to have isolated solutions. So the solutions could be legal solutions, or we come with a human rights perspective, or we say we need mandatory training or information. But in the work that we've been doing on looking at the relationship between the healthcare system, healthcare workers, and local communities and patients and their families, we've been focusing on the relationship because the relationship, the quality of the relationship, is at the heart of the importance of that connection. And that connection between frontline care providers and service users is influenced by the healthcare system itself. And we've touched upon the culture of the system, the existing power dynamics between different cadres of healthcare staff, the way that medical training and education actually primes us to relate in a certain way to each other. And I was really struck by some of the comments in earlier this morning, where I think it was Richard Horton who was talking about the need to bring together interprofessional learning and training so that nurses and doctors see themselves as equals alongside each other in developing care and providing care. And I think this is a huge mindset change. It's a huge shift from how the culture operates right now and the future that we want to create. And moving towards that future is going to take leaders and champions, and Dr. Musa spoke about this, and Francis spoke about this, champions modeling the kind of relationships and the ways of connecting with each other and with patients that we want to see in the world. And so this takes investment, but it's a very different kind of investment, because one of the things that we also have to address is the disconnect that we see between community as a geographical location happening outside of the healthcare system and the environment within the healthcare system as not being part of that community. And I think it's really important for us to sort of reframe the narrative and the paradigm to say that we are always in relationship with each other. We are always connected to each other. So when we talk about the encounter between care providers and care users, that relationship is a relationship which is influenced by multiple factors. And it's influenced by a sense of our own experiences of being in community and being members of community. And I think within WHO, one of the framings that I'm really sort of wanting to emphasize is the notion of community as being a space where people come together. It is no longer a geographical location. This is a virtual community, and we are connected based on this topic of interest, and we're also connected by the way in which the panelists also told their stories. It's personal and professional at the same time. So we also can no longer separate personal and professional because they're intertwined. How I show up in my relationships, in my professional sphere, is influenced by also who I am across these various domains. And so when Dr. Musa spoke about how stigma affected working in the hospital environment, in the community, in the family, we have to think about how our relationships are affected in all of these various domains. And so the solution also has to be around how do we begin to influence and affect the qualities of our relationships, knowing that we're all connected. So I'm going to touch upon one other area which I think affects connection. And that is, we often don't think of lived experience or living experience as data. I work with a lot of colleagues in epidemiology and clinical colleagues, and data is numbers. But data is our lived experience and our living experience. And I think this also goes back to how do we capture or make sense of how we are experiencing being in relationship with each other, the level, the strength of the connection, how compassion is being shown and emerging, and what kind of conversations we are having, because it's also the conversations that we have that impact how we feel. And so when we also look at what influences relationships, conversation, lived experience, there's an important dimension around these being informed by trauma. And I don't think we pay enough attention to how trauma, whether it's trauma in childhood, whether it's trauma through the experiences of genocide or humanitarian disasters that we experience. But our experiences of trauma primes our central nervous systems to notice danger in certain contexts. And so when we look at the experience of healthcare workers, not only are they working in challenging environments where there's shortages of staff, where people are now coming with complex morbidities, where it's not only about providing helping women deliver, it's women with diabetes who are also obese, who are also have experiencing stress in their lives. So the person it needs to be looked at in their totalities, and so the relationship also has to take into account the lived experiences of the health workforce, as well as the lived experiences of the people that they are treating and connecting with. I think there are a number of really great examples of ways that we can address stigma and discrimination and all forms of othering that we see. And one is to sort of look at leadership. Francis spoke about this. Compassion in leadership is absolutely essential. And I know that within the UK, the King's Fund and the work that Michael West has been doing on compassion in leadership has yielded some evidence around the impact that compassion training for leaders in healthcare, how important it is to create psychological safety and safe environments for the health workforce. We see them as people. Leadership and policymakers really need to understand the frontline experience of care from both sides, and then ask questions: how do we improve that? How do we optimize that encounter? And in what ways do we need to invest? So compassion in leadership, looking at connection and presence, and how we support healthcare workers to build resilience amongst themselves, because a lot of the research also tells us that our source of resilience is not what we know, it's the quality of the relationships that we have with people who have our backs. So how are relationships being built across interprofessional teams so that resilience comes from the interprofessional team itself, regardless of whether it's in a hospital, it's in a primary healthcare setting, whether it's in the community, but it's the relationship and it's the level of trust, and it's we're on the same side. And I think there's a lot of work that needs to be done within the health sector. And the interventions, we know them. It's not rocket science, and it's not reinventing the wheel. It's actually applying what we know. And I think that's where the real issue is. How can we bring all of these insights and experiences into a systemic and multi-level investment in the health workforce that enables them to deliver the kind of compassionate and respectful care that they want and they came into the profession with. Thank you. I'll stop there.
Thank you very much, Asia, for that excellent wrap-up of this session. I think we have one question here, which we can use the last few minutes to answer. It's from Sarah. She's asking, how can we best use our health worker networks and community groups to encourage uptake of COVID-19 vaccination? There is still much hesitation, confusion, and misinformation in some communities. So again, I think with the COVID vaccine, there's a lot of stigma that was attached to it, and myths and misunderstandings. So who would like to share how we can tap into our health worker networks and community groups? Or Fernando, what are you doing about that, given the Filipino Nurses Association you're working with? Have you done any work around COVID vaccination uptake?
Yes, we have done a lot of work around COVID vaccination uptake, especially when it was first manufactured and when it first came out in the market in December of 2021. And if people can remember, it was actually one of our regional officers, May Parsons, who administered the first COVID vaccine in the world outside of clinical trials. And as we know, May Parsons is now very famous because she also was the last Filipino nurse to have met the Queen before her passing a few months ago. So, with regards to the question about sorry, not raising awareness, but encouraging our uh, communities, healthcare communities, especially our Black and Asian minority ethnic communities in the UK, and working closely with the different ethnic minority groups, not only with nurses, but also with other professionals, because FNA UK is also a member of the Federation of Ethnic Healthcare Workers Minority Groups in the UK with 56 members groups. So we work together. We understand the challenges for each communities because each will have its cultural beliefs and um, lived experiences. So they have experienced previously, perhaps, a side effect from a different vaccine in the past, and that made them very fearful about this COVID vaccine. So there's a lot of education that we have to do, raising awareness, again, leading with compassion, as Aya said. And going back to our own values as well, but also taking time to understand their concerns and assuring them. So, as an association, we participated in a national drive with regards to the campaign to encourage people from all walks of life to have the COVID vaccination. I've had four COVID vaccines already myself, and I haven't suffered any side effects. So it's very important that we also live in the shoes of our communities and really listen, take time to listen and understand. And empathy is very important because, as I said, every communities will have its own religious beliefs. You have to respect their our cultural differences and backgrounds. So it's about going to their communities and listening and providing them with assurance and evidence and research information about the COVID vaccine, but also being
Yeah.
authentic to say to them that yes, there will be side effects, but this is how we could um, manage them. So thank you. Sorry about that.
Thank you, Francis, for that. Asia, please share your response to that.
Yeah, I just want to follow on from Francis. I think one of the key things that we forget is that people will tell us the exact reason why they don't want to vaccinate if we ask the right question. And I think as health workers, we are often primed to persuade rather than ask questions. And I think it goes back to what Francis was saying, that every person will have a different reason for not vaccinating. The job is to enable them to feel listened to and heard, because often we don't deal with people's emotions, we deal with the facts. And so we want to tell them the vaccines are safe, and it may not be a question of the safety of the vaccine. It may be to do with the trust in the person that's delivering it. It may be to do with the bad treatment that they've had. It may be to do with someone they know who has had a vaccine before, a different kind of vaccine, and they believe that they were harmed by it. So that conversation and the questions that we ask is really important, because then it puts the healthcare worker in a position to respond to the concerns and the needs of the person in front of them. And it's a skill and it's a way of connecting that I think we need to cultivate and develop more. Thank you.
Okay. Thank you, Asia. So since you're on the floor, there's a question here for you. How can you improve interprofessional relationship, in your opinion?
Oh, that's a big question, and I think it would take more than 2 minutes to go. Please do contact me. We have been working with some of our regional officers and country officers to prototype relationship building ways of intervening. And I think there's lots that I can say in terms of the research and the science behind some of the interventions. Yeah, I would love to have a conversation around that, and I think it's a topic in and of itself that we need to address. I think there's lots of great examples, and maybe I can share in the resources part some of the resources that people can connect to. But it's a journey. It's an ongoing, iterative journey of learning, and the shift that we need to have in looking at what is invisible. What's invisible is the way that we interact with each other. It's not about what we know, who we are, and how we show up in the relationships that we have within the interprofessional teams. And it requires self-awareness, it requires reflection, it requires individual reflection, team reflection, it requires a focus on decision-making. It requires attention to creating psychological safety in environments where people can ask questions. It's got lots of factors, but I think it's the future. I think if we can get this right, then it stands us in good stead to addressing some of the wider systemic cultural changes that we need to see happen. Thank you.
Thank you very much. Unfortunately, we've run out of time. We have a couple of unanswered questions in the Q&A. So what we'll do is share these with our panelists and try and elicit responses from them, and then get a way of disseminating these responses. I think it's been an excellent session to kickstart discussions around this hidden and yet important topic. So it's really been a very exciting session. Thank you all, our dear panelists, for sharing your experiences, and for the audience, for the questions you've raised and the comments. They are all well taken. Ben has shared a link to one of our reports that speaks to what Francis was talking about. That's THET experts in our midst work. So if you can kindly go to the chat and pick that link, and it makes good reading in line with this topic. So thank you very much.
And thank you so much to you, Sheba, for chairing a fantastic session. Extremely sobering session as well. Such an important nuance and range of kind of insights into the role stigma plays. Really fantastic. Thank you. We now shift gear actually into the concluding period of this first morning of the conference. First, we'll see a conversation, our second in conversation, pre-recorded. And then we'll move to the final talk, which is the Strategic Horizons talk from Welcome and Megan Chalice, before my colleague Rhoda Ali Ahmed will provide some concluding remarks. So the pre-recorded conversation that we're now going to watch is a conversation between two partners, Dr. Nick Bass, based in the UK, and Dr. Than, based in Vietnam. And they'll discuss, as you'll see, an example of local innovation taking place in Vietnam, which is focusing on both food security and mental health. Both those topics, of course, are intimately linked, climate change and health being intrinsically linked, as we've seen throughout this conference. We'll hear a few reflections on climate change and on mental health, and how these different contexts can learn from this innovation, and how we can exchange ideas in this area of work. So it's over to Nick and to Dr. Than.
Hello, lovely to see you. How are you?
I'm fine. How are you, Nick?
Good, thank you very much. So we're having a short discussion about the good work that you are doing in Can Hoa Hospital in Vietnam, and trying to find out a little bit about what we can also learn back from you for the UK and many other countries who will be listening in on this. So can you first, Tang, tell us a little bit about the work that you're doing at Can Hoa Mental Hospital regarding food production and how you involve your patients with this, please?
So we are carrying out in OT activity for the patient, and in terms of the productions, mostly we do with gardening therapy. Regarding gardening therapy, we have 5 different ways of gardening. The first is traditional gardening. And the second way is pot vegetable. It means we have the patient grow vegetable in a pot. And the third is hydroponic. So we use chemical nutrition to feed vegetable. The fourth way is aquaponic. Aquaponic model is we feed the fish with food, and then the fish will make their waste, and then those waste liquid will be automatically pumped into another container. In those containers, there will be microorganisms will metabolize the ammonia into nitrate, and those nitrate and nitrate will be fertilizer for vegetable. So, and the fifth waste is clean tower. So we use the rotten vegetable. We have the earthworm. We feed the earthworm with the rotten vegetable, and the worm will eat the rotten vegetable, and we make the waste. And every day the patient will come out to take those waste to pour into the vegetable for the patient to grow. And those are very organic. And and a couple of years ago, we also developed another way of gardening is mushroom grow for the patient.
Amazing. So a whole range of activities that involve not only food production, but also waste management, including composting and recycling of waste products, and all being done organically. So that's incredible. Is this food production able to feed all the patients at the hospital?
Someday, if the production is enough for providing the meal for the patient, we will use those products for the patient. Because here at my hospital, there are 150 patients every day. So if the production is not enough, so we sell out. We sell to staff, or we sell out to the market. And if the number is enough, we will feed the patient.
Okay. So it's a useful way of generating income as well as supplementing the food for the local patients. Can you tell us a bit how you involve your patients therapeutically in all of this food production and ecological waste management for the food growing?
We organize patients into different group, and each group will have different piece of land or different area for growing. So and each group will be coordinated by 2 staff, but staff play a role of coordination only. The main part of the job of the task implemented by the patient, and they need to discuss among themselves what kind of vegetable they want to grow, and they need to discuss and how the vegetable will be grown, and they will to discuss the task of each member uh, uh, among their group, and then when they finish, we help them to prepare, provide them with seeds, something like that, and labeling equipment, something like that. And then when they go out, they will sign out the role of each patient, and when they do, they will help each other.
This is amazing, and for the benefit of the viewers, these are patients with a range of severe mental health problems too. So, how do the patients find this therapeutic and helpful in rebuilding their skills and their move back to their families and communities, do you think?
They love that, because when they go out to do gardening therapy, they will go out to the environment. So when they stand in the middle of the gardening, they feel they see the air, they feel the air, they see the sky, they can sense the atmosphere, they can hear the song of the leaf, so they feel relaxed, so they feel comfortable. And I see that they reduce their stress, anxiety, and depression. So, and then when they work, they talk with each other, they interact with each other. With chronic mentally ill patient, there a lot of patients they are withdrawn. They don't talk with anybody else. But when they do gardening, they talk, and they ask for help, and they help each other. So when we observe that, we are very happy. And when they see the vegetable come out from the seed, from their daily care, they are very happy. The work bring the emotion to the patient, and they found out that they can take care of living one, and then they turn back to themselves. They take care for themselves. So they like it.
Fantastic. Thank you. So, Tang, can you tell us a little bit about where this project and all this good work it fits into addressing the climate change agenda, which is obviously an issue for different countries in different ways, but affects everybody in every country across the world. How does this work, you feel, represent an example of good practice to try and address some of those climate change issues?
I'm not sure about the impact of climate change in other countries, but in my area, I see that the number of the hurricane, increasing every year, and the rains, becoming more heavily. So and the farmer in my country, they lose their crop, frequently every year. Even in my hospital, sometimes when they do traditional gardening, and the vegetable grow very much, very nice. But after heavy rain, all the vegetable was destroyed. So that's why we need to have different way of growing vegetable, like the pot, like hydroponic, like aquaponic, because those with the pot. We can bring the pot inside the house to protect the vegetable. And with hydroponic and with aquaponic, they are already covered and they are protected from the heavy rain, from the hurricane. So it will keep the result of the patient.
Thank you very much. We're also extremely keen to know how we can learn from you and your example for other countries and also other parts of Vietnam. So we in East London work with colleagues in Africa, in Uganda, and also in Bangladesh. So Bangladesh will have, in some ways, similar problems to Vietnam, being a very fertile country, but also prone to savage winds, cyclones, flooding. And Uganda, on the other hand, is an inland country with rather different problems and a large refugee population, for instance. What is there anything that you can suggest that colleagues in different countries and maybe other parts of Vietnam can learn from the principles that you have driving your work in Can Hoa?
Yes, that's a very interesting question. You know, I had a lot of struggle and strategy 20 years ago when I first wanted to develop something for similar for my patient at my hospital. I kept looking around. I had the opportunity to travel around, Vietnam and all over the world, and I observed those activities. But then I found out that there's very little, very few. There are very few activities that I could apply at my hospital, and now I found out that we need to adapt. We need to figure out what activities is suitable for the local, what resources are available for the local. So each local have different resource. So we need to find out as a doctor, as a medical staff, as a therapist, we need to observe the resources available in the local. But with my model of gardening, there are some very simple that I think other area can apply, like traditional gardening. They can do everywhere as long as they have a piece of land, right? Small piece of land, that's enough. And hydroponic, they could apply online. They can learn that from YouTube. Aquaponic, they could learn from YouTube as well. Mm-hmm. Even with or we can make a video clip for each model, like hydroponic, like aquaponic, like green tower, and then we post on YouTube, and the people from all over the world can observe it.
Fantastic. So essentially, what I understand you're saying is that local communities should find what works for them locally and engage their patients and their communities in producing relevant and appropriate food for those communities. And okay, I think we've got maybe 1 minute left. Is there anything that any problems that you have had with your gardening projects and where you could learn back from other people from different parts of the world? Is there anything that you need to help you develop these innovations?
Yes, I do. With a carbonate model, if we do it with a small model, we was successful. But when we scale up, it means when we feed a lot of fish, so that turned out to fail. we need to have the expert in the area of fishery. We need to have support from them how to make enough fertilizer for the vegetable.
Yes, yes. Okay. Well, I'm hoping that people might put forward suggestions and discussions at the conference to help support you in this good work. Dr. Tang, so wonderful to hear from you again. Thank you very much indeed for all your great insights and work. And we look forward to comments and questions from other colleagues. Thank you.
And a huge thanks from me to you, Nick, and to you, Tan, for that conversation, which is great. I can't let Nick get away without pouring some praise on NHS East London. So probably those of you in the health partnership community know this well, but the partnership that Nick referred to with Uganda is at least as old as 2005. And it's a very good example of what we value in health partnership, which is this long-term relationship between different institutions. And in those relationships, that longevity, you begin to see the kind of equitable relationships, the honest relationship that we aspire to. So NHS East London is a very exciting outfit, and it's a very exciting health partnership. We're now turning to Megan Chalice, who is Head of Strategic Partnerships at the Wellcome Trust, and I'm delighted the Wellcome Trust are joining us to talk about their strategy. And as a sponsor of the conference, thank you for that, Megan. My impression is the Wellcome Trust is evolving in some very exciting and interesting ways. It's still about research, it's still about science, but there's also more of an emphasis on the uptake of science, and of research, and of the engagement with policy and politicians. And we've seen some of that from the contribution earlier today in one of the breakouts, where reference was made to your partnership with AMREF. I think the other reason I'm excited about you speaking is because I just feel Wellcome is very conscious of its power. Is that a way of putting it? You are keen to manage your influence in a very responsible way. For example, I think you'll be talking about the insights into racism within Wellcome Trust, but I for one think that partly we're in your debt for those insights because the Wellcome Trust has gone out and found them. It's not that you are in a kind of exceptional space. So I absolutely applaud the responsible ways in which you're managing the power you absolutely unquestionably exert. So Megan, thanks from me, and a very warm welcome from us all.
Thanks very much, Ben. That's great. I'm really delighted to be here today to speak. Thank you for the invitation, but also for just the opportunity to listen to the rest of the discussion today and tomorrow, which is all of it on themes very close to our hearts, and there's lots for us to learn from as well. So really, really happy to be here. So as Ben said, I'm Megan Chalice. I'm Head of Strategic Partnerships at Wellcome. My background is in partnerships in different sectors, so in the NHS, in academia, NGOs, government, but now running a new team at Wellcome that's been set up specifically to focus on who we partner with and how we partner. So what I'd like to talk to you today about is just to share some of the ways that we've been thinking about partnerships at Wellcome, talk a bit about how that fits into Wellcome's overall strategy, which is a new one for us as an organisation. And then maybe at the end, if we have time, to give you a few specific examples of some of the newer partnerships that we've been setting up that aren't perhaps the type that Wellcome are best known for. So thanks for a slight technical hitch. Special thanks to Kieran from THET, who is sharing my slides for me. So let's move on to the next one, please. So we've been thinking a lot recently about partnerships best practice. As you all know, as well as I do, there's plenty of it out there. But I think there's a little bit less about what that specifically means for funders. We've been thinking about best practice across sectors, thinking about where Welcome is now, where we want to get to. And this is a little bit sort of, I guess, my diagnosis of where Welcome needs to prioritise for now. So what we aren't always managing to do yet in our partnerships or do well. The first one is outcome focused. So this starts with being clear, obviously, as an organisation about where you want to get to, knowing your own strategic goals. And we do now as an organisation who have finally got to our new strategy. And that means that we're in a position to be able to sort of share and co-develop objectives with partners in a much clearer way than we have done before. That way, all parties in a partnership know what we're trying to achieve, and then crucially, we can all measure and know whether it's working or not. Secondly, genuinely equitable, mutually beneficial. Obviously, this is true across the board, but as Ben said, we're particularly, I think, at Welcome, cognizant of the fact that we are in a different position as a major funder, and that we need to be more aware of this than many others. Trust and two-way communication. I think this is particularly relevant for Welcome as a big organisation that's recently been through a lot of change. I hear a lot from partners that I talk to that it's just harder to know how to engage with Welcome now. And so we need to be aware of that. In the equitable partnership session we had this morning, this was, I think, put in an even better way, which is mutual trust and respect, that needs to be the foundation of partnerships that we run. And then finally, sustainability. It's not always, of course, the appropriate thing, but where it is, partnerships being longer term. I think Welcome is a politically and financially independent organisation. We're in a position where we can commit to things in the longer term that it's more difficult for other organisations to do. I know that well coming from a government background. And so where that is the right thing to do, we want to do that. The next slide, please. So we believe that in our new strategy, partnerships are really sort of the key drivers to us having an impact, that without them, we won't be able to achieve this sort of like catalytic change that we need to actually do it. It's part of the reason why we now have a centralised partnerships team for the first time. But this slide is a bit about why we believe that, I suppose. It's about us helping us to overcome some of the barriers that we know that we face if we want to try to deliver this strategy. A few of those, I guess, one of the major ones is the challenges we're trying to tackle are really complicated. They're in many cases very busy spaces with lots of different actors already. And so we need partnerships to help us contribute to those spaces and to do so effectively. We need help to understand where we can add value and, more importantly, maybe where we can't. Secondly, Welcome is a newcomer to some of our challenge areas, and especially climate and health. And I think partnerships help us learn, help us understand the space better where we don't necessarily have the credibility that we want to have in the future. And they help us start to make an additive contribution to a field rather than sort of going in without knowing what that would look like. Thirdly, one of the most important things, we have a very limited global footprint. Of course, in our core staff, we're mostly based in London. Even when you take some of our existing major partnerships into account, that's still the case. So we need partnerships if we want to have the global approach that we're going to need for this strategy. And then finally, the things that we're trying to tackle are huge global health challenges, and they require big change and simply change that we would never be able to achieve by ourselves and never be able to fund by ourselves either. The next slide, please. So this is about, I suppose, maximising the impact of our partnerships. And this is just to give you an example of a framework that we've been using to think about that. It's really to help us think about sort of where working together with another organisation or multiple other organisations helps both of us to deliver something that neither organisation could do by ourselves. So strengthening capabilities, for us this is about, for example, we might invest in partners who are doing world-class research or other organisations who have specialist expertise that we won't ever have in Welcome. Leveraging resources might be about joint or pooled funding with others and using that as a mechanism to take some collective action on these really big and complicated things. And extending reach, I've talked about that already, but it's very clear, right, with this strategy, we need to better understand local contexts, we need to ensure our work's informed by those most affected, and we need to be grounded in local realities in a way that we can't be by ourselves. We're reliant on partners to help us to do that. And we have equity in the centre here. We have that because we see it as a prerequisite to a successful partnership. That's why we want it to be at the heart of this framework. We're thinking about it a lot, and thank you so much to those of you who were able to join our discussion earlier today. That was really helpful for us. This has been a priority for Wellcome for a long time, particularly in our research partnerships. But as Ben said, about 2 months ago, we published an anti-racism report. Many of you may have seen it. I guess it's really concentrated minds on this inside Wellcome and given it even more momentum. It is quite a difficult read. If you haven't seen it, it's available on our website. But we are pleased that it's been published because it helps us to increase the transparency about this and accountability for us as an organisation going forward as well. The other thing I found really positive is just in speaking to lots of our partners about it, it feels like a lot of organisations are going through starting perhaps a similar period of kind of reflection. And that's really positive for us because we feel it gives us a chance to work collaboratively with others when we start this journey. The next slide, please. So just to give you some context, how does sort of this all fit with Wellcome's overall strategy? Many of you may have known the organisation for a few years and it does look quite different now. We've narrowed our focus quite a bit to focus on these 3 big global health challenges: infectious disease, climate and health, mental health. In each of these cases, the communities most affected are obviously in the global south. So we can't do this strategy unless we take a more global approach and unless we work more in partnership. The big numbers, I guess, are that we have committed to spending £16 billion over the next 10 years to fund the sort of science-based solutions to these challenges that we're looking for. Just to add a couple of points that aren't on this picture, we've also got a research environment team that's specifically about our commitments to open research, ethics and research culture, and a data for science and health team, which is around the technologies, policies and kind of communities needed for data and digital tools to make a contribution to this mission. Next slide, please. So just to dive a little bit into each of these, infectious disease, our vision here is a world in which there's a reduced risk and impact of escalating infectious disease. And our focus here is really on preventing the future escalations of those diseases. So for us, a few things that incorporates: understanding what causes outbreaks and drives those escalations of disease. It's about looking for sustainability and equity in the development of the tools that we want to create, and with that focus on communities at greater risk, as well as looking at how diseases are mapped and measured to better predict the outbreaks that might happen and give us the chance to intervene earlier. Next slide, please. Climate and health. So this is about us wanting to see a world where catastrophic climate breakdown is averted in a way that allows human health to flourish. And we talk about this in the sense of Wellcome is trying to bring health to the heart of climate change action. So we're supporting science, of course, to generate the evidence that is needed to spur action here, but also with a real recognition that sort of that evidence alone isn't enough, right? So that we need that evidence to inform action on mitigation, on adaptation, but also to try to help create a global climate and health community that's sort of equipped to take the kind of action and have the impact that's needed here to tackle this issue. Next slide, please. Then the final of our 3 challenge areas, as we call them, is mental health. Our vision is a world in which no one is held back by mental health problems. Here, to put it most simply, we're looking for more effective solutions. We're looking particularly at anxiety, depression and psychosis, how those develop and how they can resolve. And we're really looking at early intervention. So we're looking for better ways to be able to intervene early, to stop these conditions escalating and to hopefully prevent, in more cases, them becoming lifelong problems. And again, there's a field building element here as well. So building a more integrated field of mental health science with a particular focus on really integrating lived experience into that and having that as the centre of that field going forward. Next slide, please. Finally, discovery research is our term for research across any discipline that's leading to new knowledge and insight into life, health and well-being. I think this is probably what Wellcome is really best known for, and we continue very much our commitment to it, especially at a time when I think many funders are starting to move away perhaps a bit from supporting this kind of curiosity-based research, perhaps moving towards things that feel like they have a more measurable, closer term impact. But we feel that, again, sort of Wellcome's position is such that we are able to fund research over a long period of time. We're able to do that even where maybe that link to impact isn't completely immediately clear. And so we believe that we should, and we will. These are, on the right-hand side here, are award schemes. They've been simplified quite a bit from the previous. We used to have many more. And they're now based on career stage. So you can look at our website for details of what's in and out of scope and kind of all of that. Maybe a couple of things to mention. Applicants can be from any low and middle income countries, Ireland or the UK. And we're particularly interested in cross-disciplinary applications and building those cross-disciplinary approaches. Next slide, please. So to move on to just a couple of examples of some of our recent partnerships. We obviously have a really long history of partnering in different ways in lots of parts of the world and with lots of different models. Many of you will know some of our kind of bigger, more institutional based partnerships like the Africa and Asia programs or the India Alliance, Deltas. What I thought it would be interesting to tell you about today is just some of the types of partnerships that we're less known for, maybe either where we're trying new types of partnerships or sort of trying things that are about new challenges and barriers where we think partnerships might be the key to unlocking it. So in this case, I guess some of you might know the Wellcome Collection. So that's our museum that's next to our headquarters in London. Because we've got this museum and have had since we were set up, it means that this kind of cultural programming is really part of the fabric of Wellcome. It's a bit baked into our DNA. But I think it's fair to say we're starting to think about it in some new ways now, and a bit more focused on sort of leveraging these projects towards the change that we want to see. Not just for their own benefit, which of course they have. So we have a specific cultural partnerships team who we work with very closely. And one of the projects they're working on is in the Wellcome Hub. And the Hub is a specific transdisciplinary research space within the Wellcome Collection Museum itself. And it's a residency program. So there's always a residency there. The current organization are called Land Body Ecologies. They're really focused on researching solastalgia, which is a developing field in global health. And it's about the sort of emotional, existential distress that can be caused by environmental change and land rights issues. That really nice quote on the slide there, the feeling of homesickness when you're still at home. And they use that lens to really think about the lived experience of land trauma on marginalised and also Indigenous communities. Indigenous communities are actually really at the heart of the programme, and as well as this sort of London hub, there are also hubs in Kenya, Uganda, India, and in Northern Europe as well. And the work is really carried out through these hubs, so from everything from developing research questions onwards. We're learning loads from working with LBE just in terms of their overall approach, and I think many others could too. If you'd like to hear a bit more about what they're doing, I'd really recommend looking at their new podcast, which was just launched a couple of months ago and has some really, really nice, interesting details and case studies of what they've been doing. Next slide, please. So Ben mentioned this one. We talked a bit about this morning as well. It's an advocacy partnership, which is a quite new territory for Wellcome. It isn't what we're known for, partly because we didn't do it until recently. But we do believe that it's going to be quite an important tenet of what we need to do to achieve our strategy going forward. AMREF is an organisation we have a lot of overlapping priorities with, so it was a sort of fairly obvious contender. One of their big strategic priorities is also climate and health, so there's a clear overlap there. And they've been keen to focus on climate and health advocacy capacity specifically. That's what we're working with them on here. And it's really looking at capacity in terms of both within AMREF, but also other CSOs in their networks. It's scoping, so looking at what would work and what's needed in climate and health advocacy in the region. And it's about convening, so bringing more diverse voices together at global events like COP to together put health at the heart of climate action. Next slide, please. So then final example is a really different one. It's a partnership we're looking at, it's about system change, really. I think we at Wellcome learned during the pandemic what can be achieved when the global community comes together. That was what the ACT Accelerator was about, but also the limitations of those partnerships when they aren't diverse. We think reformed global health ecosystem that's more efficient and equitable is basically a sort of prerequisite if we want to see any progress across our health challenges. And so for us, one of the things we're trying in order to make a difference there is being a founding partner of the Financial Intermediary Fund for PPR. So the idea behind this partnership is about raising new money for global preparedness against infectious disease, and specifically about capacity to identify and manage outbreaks, both at country and regional level, which I think, as we all know, is a huge gap that we saw with COVID-19 and other epidemics as well. One of the main things that we've been prioritising here as a partner is thinking about the governance model and how to design that to learn from those previous examples, and to be more equitable from the beginning, have more equitable outcomes, and have a greater impact for the affected communities predominantly. And we're thinking about that in different ways, whether it's through civil society consultation process that's been based around CSOs in the Global South, or something as concrete as board seats for the countries eligible to benefit from the fund as well, to avoid that sort of donor-centric model going forward. Next slide, please. That's everything I wanted to say, but really to say we'd love this to be the start of a conversation with all of you. Some ways to keep in touch with us. If you're interested in hearing about our funding models and the kind of funding calls that will be coming out, you can subscribe to the newsletter on our website. You can contact our grants information officers who are there for specific questions, or do contact us in our partnerships team at that address as well. We'd really love to continue this conversation. Thank you.
Thank you very much, Megan. That was very interesting to listen to. Is there any question for Megan before I start with the closing remarks? Yeah, okay, perfect. Then let me start by our closing remarks for today. I can just start by saying good afternoon, everybody. Wow, it has been amazing, really, listening to all the participants from everywhere and really listening to the voices from around the globe. It is interesting to see the number of participants who came to this event and the voices which is ensuring that there are partnership and solidarity all over the world. I would like to, we took so many, there's so much to reflect on. I don't know really where to start with. Let me start by Dr. Tedros from WHO, who was emphasizing on the need for partnership to ensure that there is an equity and equality in healthcare services, specifically in regard to vaccination. It was amazing to listen to Dr. Richard Horton speech earlier today, this morning, where he talked that he is still, in spite of the dynamic and chaotic world that we are living in today, he's still very optimistic about the importance of partnership in achieving healthcare and equity for all the world. And then also exploring and emphasizing the importance of bottom-up and top-up approach as well also. And he was asking the international community and specifically policymaker and diplomatic and leadership, specifically in the donor community, to revisit their commitment towards alleviating disparity in regards to health and poverty in the less developed world. So that was something to take away, in spite of all the challenges that are present in our world. We've looked through Dr. Horton's presentation into the interprofessional training as a mean for improving the quality of healthcare, and also the collaboration between various health team workers. We are still looking into issues around international health worker migration from low and middle income countries into developed world. And then there is a room also for collaboration between countries and as an international level to make sure that those people are coming back to their community. So I guess there is a need for us to look from those more developed countries that our health workers are migrating to, and those low and middle income countries that the health workers are leaving, that they think how they can collaborate and making sure that the benefits are reciprocal or exchanged by both ends, and making sure that they come back and there are some benefit for the low and middle income countries. We've discussed today, over the afternoon session, the relationship between interprofessional team as an holistic approach when we were listening to ASEA, as an holistic approach to ensuring quality of healthcare services, and also including issues like the environment, the culture, the community, the dynamic, the policy, the type of leadership, the training, and all that, and impacting the relationship between health worker. Thus, as a bridge to ensure that we have quality healthcare services for our community. During the day presentation, we've witnessed the fruit of partnership, and that's through the presentation of her Honorable Sylvia Masuba, the Minister of Health in Zambia, when she was shedding light on the fruit achieved in Zambia through the partnership, specifically in vaccination and all. And she was also reminding, as Dr. Horton said, she was reminding the international community, the UK leadership, that the commitment is there and the need is there, and they would need to be, in spite of all the challenges, from climate change to political turmoil, to energy problems, economic problem, that the need is there to revisit and also to reconsider and continue the support which is extended towards low and middle income countries. In our presentation this afternoon, we looked at the climate change all over the world. Our health and well-being are interactively linked to our nature and natural environment. So much, in fact, that the World Health Organization has called climate change the single biggest health threat facing humanity. So there is a need for collective partnership in improving the climate condition, measure to protect our nature, limit the plastic, as we said in the presentation from Aliyah and his team, and the pollution, invest in better and smart agricultural endeavors or initiatives. We looked through the presentation from different voices, from Philippines, from John, from all of them. They were talking about initiative. This initiative in tackling climate change and dealing with climate, with pollution and recycling issue is very important, that we learn from, document, and see how we can benefit and share experience through different countries. We had the brilliant presentation and benefit of partnership through visiting the impact of it on health workers who are working in low and middle income countries. We've looked at the experience from Nepal, Philippines. We've looked at the experience from Paul Matthew and Adibio Aladi. They looked into a reflection of how the partnership and their visit to Uganda has enriched their career, has enriched their personality, and made them improve in terms of leadership, decision-making, and teaching and training and expertise and project management. So actually, this is telling us that partnership benefit and fruits are both ends, from the south to the north. So it's not only one area benefiting. We've looked at possible, through Megan's presentation, the last presentation, and what are the partnership strategies and requirements? What are the challenges that are there, and we need to address it? I can say that today's the first day presentation was astonishing, and there are so much to reflect on and to learn about. I would like to extend my thanks to THET team for all the amazing presentation, and also the organization of the team and effort, and for all those people who had the time and effort to participate and actively have their voices heard in issues around partnership and healthcare improvement. I would like also to thank our sponsor for making it accessible for low and middle income participants or health worker to participate, and also for our partners at THET. Thank you very much. I'm looking forward to have you tomorrow morning.